Welcome to the Deep Dive, the show where we take complex topics, sift through a stack of sources, and really extract the most important nuggets of knowledge. Our mission, well, is to give you a shortcut to truly mastering the material, providing you with surprising facts and just enough humor, hopefully, to keep you hooked.
Yeah, that's the plan.
Today, we're plunging into an organ that, despite its absolutely critical role in our daily function, often remains a complete mystery. You know, you barely think about it.
Right, until something goes wrong.
Exactly. Until something, well, really goes wrong. It's a hidden hero, a small but mighty gland that plays this kind of dual role in our body's chemistry. The pancreas.
Indeed. And most people, they know the pancreas for its role in producing insulin, regulating blood sugar.
Most part, yeah.
That's its endocrine function. But its powerful exocrine function, its ability to churn out these digestive enzymes, is often overlooked. So this deep dive will unpack the intricate world of the exocrine pancreas. We've drawn heavily from authoritative medical sources, particularly a gold standard like the SABISTON textbook of surgery, to distill the most critical insights.
Right.
Our goal is to give you an expert-level understanding, from its microscopic workings to complex diseases and cutting-edge treatments. We want to offer both foundational knowledge and some truly surprising details.
So, like getting the deepest understanding without having to wade through those dense medical texts yourself.
That's exactly the idea. A shortcut to mastery.
All right, consider us hooked. Let's unpack this hidden hero, starting with its fascinating anatomy and how it even comes to be. So if you were to actually picture the pancreas inside your body, how big is it? And where exactly does it live?
It's surprisingly compact, typically weighing between, say, 75 and 125 grams.
Oh, not much.
No, not much heavier than a bar of soap, really.
Yeah.
And measuring about 10 to 20 centimeters in length. It's tucked away deep in your retroperitoneum.
Retroperitoneum, meaning behind the abdominal lining.
Exactly. Behind the lining of your abdominal cavity.
Yeah.
Positioned right in front of your first lumbar vertebra, so essentially at the back of your abdomen.
That sounds like a pretty protected, almost hidden spot, but it's not just one uniform shape, is it? I heard it has distinct sections.
That's right, yeah. It's anatomically divided into 5 sections. You've got the head, the uncinate process, the neck, the body, and the tail.
Okay.
The head is the broadest part, and it's nestled perfectly within the C-shaped curve of the duodenum.
The first part of the small intestine?
Exactly, the very first part. And this positioning is incredibly important because it means the pancreatic head lies right in front of the vena cava, one of your body's largest veins.
Wow, okay. And the uncinate process, that's a unique name, almost like a hook.
It is. It looks like one. The uncinate process is essentially an extension that curves out from the lower part of the head, almost like a little hook. Yeah.
Okay.
What's crucial about its path is that it passes behind the superior mesenteric vein, the SMV.
I got it.
And terminates right next to the superior mesenteric artery, or SMA.
Those are major vessels, right, supplying the intestines.
Absolutely vital blood vessels in your abdomen. So for surgeons, understanding this precise relationship is, well, it's absolutely non-negotiable. It directly impacts how they plan and execute procedures, especially if there's a tumor in that area.
So the uncinate process is tucked behind some pretty significant plumbing. What about the neck, body, and tail? They extend across the rest of the abdomen.
Right. The neck is just a short segment directly overlying the SMV.
Right.
From there, the body and tail extend across the midline, slightly upwards, passing in front of the Geroda fascia.
That's the capsule around the kidneys?
Correct, that fibrous capsule around your kidneys. The tail ultimately terminates within the splenic hilum, which is where blood vessels and nerves enter and leave your spleen.
Okay.
Now, unlike the other sections, the transition point between the body and tail is actually quite, well, the book calls it nebulous, meaning there's no clear-cut line where one ends and the other begins. But understanding these precise anatomical relationships, where the pancreas sits relative to the duodenum, those major blood vessels, the spleen, it's absolutely crucial.
Why is that so critical?
Well, it helps diagnosticians understand how diseases like cancer might spread, and it guides surgeons in their approach. A tumor in the head might quickly involve the vena cava, while a tail tumor could affect the spleen directly.
Location, location, location.
It's a prime example of why location truly is everything in medicine.
That makes perfect sense. Given its central, deep location and its connections to so many vital organs, I imagine its blood supply and drainage are equally intricate.
Absolutely. The pancreas isn't just intricate in its structure. It benefits from an incredibly rich and complex arterial network. It essentially has a dual blood supply.
Dual supply, like a backup.
Sort of, yeah. It draws from two major arterial systems,
Yeah.
the celiac trunk and the superior mesenteric artery, which both branch off the aorta.
Okay, so a backup system built right in. How does that dual supply break down for each section of the pancreas?
So the head and the uncinate process primarily receive their blood from what we call the pancreatico-duodenal arteries.
Pancreatico-duodenal. Made sense.
Right. And these are divided into superior and inferior branches, which themselves have anterior and posterior components. It gets pretty detailed.
Okay.
The superior pancreatico-duodenal artery originates from the gastroduodenal artery, which is a branch off the common hepatic artery.
Right.
The inferior pancreaticoduodenal artery, on the other hand, comes off the superior mesenteric artery, the SMA.
Okay, so different sources.
Exactly. And these branches then beautifully connect to form an intricate arterial arcade. Think of it like a circular highway
Oh, okay.
that supplies not only the head and uncinate process, but also a significant portion of the duodenum itself.
So a really robust, interconnected supply for the head. What about the rest of the pancreas? The neck, body, and tail?
They're primarily supplied by branches coming directly off the splenic artery as it courses along the upper border of the pancreas.
Okay.
You have arteries like the dorsal pancreatic artery, which actually runs behind the body of the gland and then often continues as the inferior pancreatic artery, extending all the way to the tail.
Wow.
There's also the greater pancreatic artery contributing to this supply. This extensive interconnected arterial network is a major advantage during complex surgical procedures.
How so?
Well, it ensures that even if one vessel is compromised by disease or needs to be divided during surgery, there are collateral pathways to maintain blood flow, minimizing the risk of tissue death. It's a natural failsafe.
That's a good system to have. And venous drainage. Does it mirror the arterial supply, like a river flowing back?
Largely, yes. The venous drainage generally follows the arterial pathways, collecting that blood. Blood from the head drains into the anterior and posterior pancreaticoduodenal veins.
Okay.
For instance, the posterior superior pancreaticoduodenal vein typically flows directly into the superior mesenteric vein, that SMV we mentioned.
Right.
The anterior superior often joins another vein before merging with the SMV. And the inferior pancreaticoduodenal veins drain into the SMV near the uncinate process.
And the body and tail.
They mirror their arterial supply. They're drained through the splenic venous system, which then merges with the SMV to form the portal vein.
The portal vein taking blood to the liver.
Exactly, carrying all that nutrient-rich blood to the liver.
And beyond blood, what about the lymphatic system? This is often critical for understanding disease spread, especially cancer, right?
You're hitting on a paramount point, particularly for surgeons dealing with pancreatic cancer. Understanding the lymphatic drainage is absolutely critical for performing a complete and effective oncologic resection.
Okay.
Imagine the pancreas having 4 distinct quadrants of primary lymphatic drainage. These essentially form a protective ring of lymph nodes around its border.
A ring of nodes.
Yeah. On the left side, the body and tail lymphatic fluid drains to nodes in the splenic hilum, or the gastrosplenic omentum, following channels along the top and bottom borders of the pancreas. These channels contain small embedded lymph nodes, like little checkpoints.
So the left side is all about the spleen. What about the right, around the head?
On the right side, the head and uncinate process drain both superiorly to gastroduodenal lymph nodes and inferiorly to infrapancreatic lymph nodes.
Okay.
Again, small nodes are interspersed along these pathways, completing that ring of primary drainage. But it doesn't stop there.
Oh, there's
Yeah.
more.
There's a crucial secondary drainage pathway, the retropancreatic lymph nodes. These are located deep in the abdomen, right in front of the aorta, nestled between the celiac and superior mesenteric arteries.
Okay, deep ones.
These retropancreatic nodes can be either first order, receiving drainage directly from the pancreas, or second order, receiving drainage from that ring pathway. This highly detailed understanding of lymphatic flow is what guides surgeons in performing a meticulous lymphadenectomy, removing lymph nodes during cancer surgery. It's about ensuring they remove all potentially affected nodes to prevent local recurrence and improve a patient's chance of survival.
That's an incredible level of detail, showing just how interconnected and strategically placed this organ is. But before it becomes this complex network, how does the pancreas actually form? let's talk embryology.
The development of the exocrine pancreas is a fascinating journey, really. It begins quite early in gestation, specifically around the 4th week of embryonic development.
4th week, okay.
At this stage, you have these remarkable pluripotent pancreatic epithelial stem cells. Think of them as blank slates.
Very versatile.
Incredibly versatile. They have the extraordinary ability to give rise to all the diverse cell types found in the mature pancreas. The exocrine cells making enzymes, the endocrine cells like insulin producers, and the intricate ductal network.
So it all starts with these stem cells. What are the very first structures we see forming?
The initial structures are 2 distinct outgrowths, almost like little buds, from the primitive duodenal endoderm, the inner lining of the developing gut.
Okay.
These are called the dorsal and ventral buds. The dorsal bud typically appears first, and it's destined to develop into a significant portion of the mature pancreas. Specifically, the superior part of the head, the neck, the body, and the entire tail.
So most of it comes from the dorsal bud.
A large part, yes. The ventral bud, on the other hand, develops as part of the hepatic diverticulum, which also forms the liver and gallbladder.
Ah, okay.
Crucially, this ventral bud maintains its connection with the developing biliary tree throughout its growth.
And what parts of the pancreas does the ventral bud ultimately become?
The ventral bud primarily forms the inferior part of the head and that uncinate process we talked about.
The hook part.
Exactly. Now, the real marvel of embryological choreography happens between the 4th and 8th weeks. During this period, the ventral bud undergoes a critical rotation. It literally moves posteriorly in a precise clockwise fashion, rotating around the duodenum until it eventually fuses with the larger dorsal bud.
Wow, it rotates around the gut.
It does. This fusion is typically complete by around 8 weeks of gestation, establishing the single, unified pancreatic gland we see in adults. It's an intricate dance of cellular migration and fusion.
That's a lot of intricate movement in a short time. What controls this process at a molecular level? Are there specific genes or pathways guiding this?
This is where it gets really interesting, showing the genetic blueprint in action. The initiation of bud formation and that differentiation of a ventral bud are critically dependent on specific master regulator proteins.
Master regulators.
2 of the most important are pancreatic duodenal homeobox 1, or PDX1, and pancreas-specific transcription factor 1, or PTF1.
PDX1 and PTF1.
Yeah. For example, in studies with knockout mice where you deactivate specific genes, if PDX1 expression is knocked out, the pancreas simply doesn't form.
Wow, completely gone.
Completely gone. It powerfully illustrates its essential role very early on. PTF1 expression becomes detectable shortly after PDX1, and analysis shows 95% of acinar cells, the enzyme producers, express PTF1.
Okay.
In mice where PTF1 is absent, no acinar cells form at all.
So PDX1 and PTF1 are like the master switches dictating its very existence. Are there other signals involved in guiding cell fate?
Absolutely. The Notch signaling pathway is another vital player, particularly in guiding duct and acinar differentiation, keeping cells on the right path.
Notch signaling.
What's fascinating here is that in the absence of Notch signaling, embryonic cells actually commit to the endocrine lineage.
So they become insulin cells instead.
Exactly. They become insulin-producing cells instead.
Yeah.
This suggests that Notch signaling is crucial for suppressing endocrine development to promote the exocrine differentiation that forms the bulk of the pancreas.
Interesting.
Beyond these, there are complex interactions with various growth factors like TGFA and other signaling pathways like hedgehog and white. These all play critical, interconnected roles. The precise interactions are still being defined, but it's clear it's a tightly regulated molecular dance where every step matters.
That complex dance sounds like it has many opportunities for missteps. What happens when this development goes awry?
Yeah, when that precise embryological dance hits a snag, it can lead to several congenital anomalies. One of the most common is called pancreas divisum.
Pancreas divisum, divided pancreas.
Essentially, yes. Normally, the primitive ducts of both the dorsal and ventral pancreatic buds fuse together. The smaller dorsal duct often forms a channel called the ductus Santorini, draining through opening the minor papilla in the duodenum.
Okay.
The larger main pancreatic duct, or duct of Versung, is formed by the fusion of the distal dorsal duct with the ventral buds duct. It joins the common bile duct at the ampulla of Vater, entering the duodenum through the major papilla. This duct of Versung is usually the primary drainage pathway.
So pancreas divisum means they just don't fuse properly?
Precisely. In pancreas divisum, the dorsal and ventral ducts fail to fuse completely. This means the ventral pancreatic duct, along with the common bile duct, continues to drain normally through the major papilla.
Okay.
But the dorsal pancreatic duct, which actually drains most of the pancreas's exocrine secretions, is forced to drain independently through that much smaller minor papilla located slightly higher up.
That sounds like a bottleneck. A small drain trying to handle a big sink. Does that cause problems?
It absolutely can. Because most pancreatic secretions try to exit through this relatively small dorsal duct and minor papilla, it can lead to a condition of partial obstruction.
Ah, okay.
This creates chronic back pressure in the dorsal duct, which has been implicated in the development of relapsing acute or chronic pancreatitis.
Right.
What's interesting, however, is that while pancreas divisum is quite common, affecting about 10% of the population.
10%? Wow.
Yeah, it's common. But only a small minority of those individuals ever develop symptoms or pancreatitis. So it's a common anatomical variant, but symptomatic disease is rare. Many people live with it their whole lives without issue.
Fascinating. What about annular pancreas? That sounds like the pancreas literally forms a ring around something.
That's essentially what happens. Annular pancreas results from an aberrant migration of the ventral pancreatic bud during development.
Went the wrong way.
Exactly. Instead of fusing normally, it mistakenly grows to encircle the second portion of the duodenum, creating a ring of pancreatic tissue around it.
Oh, wow.
This abnormality can be associated with other congenital defects, like Down syndrome, intestinal malrotation, intestinal atresia, and various heart malformations.
So if it's encircling the duodenum, I imagine it can cause an obstruction, like squeeze it shut.
It can. If the patient develops symptoms of duodenal obstruction like severe nausea, vomiting, difficulty eating, surgical bypass is performed, typically a duodenogenostomy, rerouting food around the obstruction. It's crucial not to simply divide the pancreatic tissue forming the ring.
Why not? Seems like the simple solution.
Because this annular pancreas contains its own pancreatic duct. Dividing it would almost certainly lead to a pancreatic fistula, where digestive fluid leaks out. That's a highly undesirable and morbid complication.
Right. Makes sense. So bypass is safer.
Much safer, more effective approach.
And finally, ectopic pancreas. Does that mean pancreatic tissue growing where it shouldn't?
Yes, that's exactly it. Ectopic pancreas refers to pancreatic tissue found anywhere along the primitive foregut, the embryonic structure that gives rise to much of the digestive tract.
Okay.
It's most commonly found in the stomach, duodenum, or even in the Meckel's diverticulum, a common gut anomaly.
And does it cause problems?
Clinically, these ectopic nodules can sometimes cause symptoms like bowel obstruction if they lead to part of the intestine telescoping into itself, intestinal or bleeding and ulceration. Often, though, they are found incidentally as firm, yellowish nodules during other procedures or imaging.
Is it dangerous? Like, can it become cancerous?
Well, there have been very rare case reports of cancer arising in ectopic pancreatic tissue, but it's extremely uncommon. Resection is generally only necessary if the patient is symptomatic. Otherwise, they can often be left alone.
It's remarkable how many ways development can vary. But now that we understand how the pancreas is built, let's dive into what it does on a daily basis. How does this hidden hero function?
The human pancreas is indeed a complex gland. As we mentioned, it has both endocrine functions, insulin, glucagon for blood sugar, and the exocrine functions, our focus today, absolutely essential for digestion.
Right, the digestive part.
Structurally, it's a powerhouse of specialized cells. About 85% of the gland is made up of acinar cells. They're the workhorses of exocrine function.
85%, wow.
Yeah, only about 2% are islet cells, the endocrine component. The rest is a complex network of extracellular matrix, the duct system, and blood vessels.
So 85% acinar cells, making it a true digestive factory. What exactly do these cells produce, and how do they ensure it only works outside the pancreas?
Their primary function is to provide the vast majority of enzymes needed for breaking down the food we eat. Acinar cells synthesize a wide array of enzymes. For proteins, they produce inactive versions called proenzymes.
Proenzymes, okay, like pre-enzymes.
Exactly. Things like trypsinogen, chymotrypsinogen, procarboxypeptidase, and proelastase. These are fascinating because they're stored safely within the acinar cells in tiny packets called zymogen granules.
Zymogen granules, got it.
When the pancreas is stimulated, these proenzymes are secreted into the pancreatic duct and then into the duodenal lumen.
Why inactive? It sounds like a critical safety mechanism. What activates them in the duodenum?
They're inactive for a crucial reason. self-protection.
Ah, makes sense.
If they were active inside the pancreas, they'd simply digest the organ itself. Their activation is a carefully controlled cascade, like a biological ignition sequence.
Okay.
The duodenal mucosa has a special enzyme on its brush border called enterokinase.
Enterokinase.
This enzyme is the critical trigger. It acts like a key, catalyzing the activation of trypsin from trypsinogen.
Okay, so trypsin gets activated first.
Yes, and once trypsin is active, it then plays an even more important role. It auto-activates more trypsinogen and also activates all the other proenzymes like chymotrypsinogen, procarboxypeptidase, and proelastase.
Wow, like a chain reaction.
It's a precise chain reaction, ensuring maximal digestive power once the enzymes are safely in the intestine, ready to break down your meal.
So, a tightly regulated, almost explosive system. What other active enzymes do acinar cells produce beyond the protein-digesting ones?
Good question. In addition to the proteases, acinar cells also produce pancreatic amylase and lipase as active enzymes.
So they don't need activation.
Correct. They don't need that duodenal activation. Pancreatic amylase is responsible for hydrolyzing major polysaccharides, think starches, into smaller sugars.
Okay.
Pancreatic lipase is critical for fat digestion. It breaks down ingested fats into free fatty acids and smaller components your body can absorb. There are also other fat-digesting proenzymes like cholipase, which is vital because it stabilizes lipase activity in the presence of bile salts, preventing inactivation.
Okay.
And to handle nucleic acids, acinar cells secrete deoxyribonuclease and ribonuclease for breaking down DNA and RNA. It truly is a full suite of digestive tools.
It sounds like an incredibly potent cocktail of enzymes. You mentioned the pancreas has mechanisms to protect itself before they reach the duodenum. What are those internal safeguards?
That's a vital point, and it speaks to a key autoprotective mechanism. Beyond being synthesized as inactive proenzymes, acinar cells also produce a special protein called pancreatic secretory trypsin inhibitor, or SPNK1.
SPNK1, like SPINK1.
Exactly. Think of this inhibitor as an emergency brake or a counteragent. It directly counteracts any premature activation of trypsinogen that might occur inside the acinar cells, keeping the peace.
Okay, an internal policeman?
Kind of, yeah. And what's particularly relevant for later discussions is that mutations in the SPNK1 gene are actually associated with chronic pancreatitis, especially in childhood.
No.
It highlights the critical role this protective mechanism plays in preventing the pancreas from self-digesting.
So the acinar cells produce the enzymes and the built-in safeguards. What about the duct cells? Are they just a plumbing system, or do they play an active role?
Far from just plumbing. The pancreatic duct cells have a primary and crucial function. They provide the massive amounts of water and electrolytes necessary to dilute and deliver those concentrated enzymes from the acinar cells.
Okay, so they add the liquid.
Exactly. Without adequate fluid, the enzymes would be too viscous to flow properly and function effectively. Imagine trying to send thick mud through a straw. It just wouldn't work.
Right, so they add water. What about bicarbonate? I've heard that's important for neutralizing stomach acid.
Absolutely essential. The concentrations of bicarbonate and chloride in pancreatic juice vary depending on the phase of digestion, but bicarbonate is key. The mechanism of bicarbonate secretion is complex and elegant, like a microscopic chemical plant. It starts with carbon dioxide, CO2, diffusing from your bloodstream into the ductal cells. Once inside, an enzyme called the carbonic anhydrase rapidly hydrates the CO2, producing both bicarbonate, HCO3, and hydrogen ions, H+.
Carbonic anhydrase. I remember that from basic chem.
Yep. And how does that bicarbonate actually get into the duct?
Yeah.
On the apical membrane of the duct cell facing the duct lumen, there's an anion exchanger. This pumps bicarbonate out into the lumen while pulling chloride in from the lumen.
A swap.
A swap, exactly. What's fascinating here is its interaction with the cystic fibrosis transmembrane conductance regulator, or CFTR.
CFTR, that's linked to cystic fibrosis, right?
Precisely. Studies show this exchanger works in tandem with CFTR. And importantly, mutations in the CFTR gene are directly linked to chronic pancreatitis.
Yeah. So that's the connection.
It correlates perfectly with what we see in CF patients.
Yeah.
Their inability to secrete water and bicarbonate properly leads to thick, viscous secretions that obstruct the ducts, causing severe pancreatic issues. There are other specialized transporters involved too.
So CFTR mutations can lead to pancreatitis because the ducts can't secrete bicarbonate properly, affecting enzyme flow.
Precisely. Impaired water and bicarbonate secretion leads to thicker, more concentrated juice, prone to blockages and inflammation. Now, what about those hydrogen ions produced from CO2?
Yeah, what happens to them?
They're actively pumped out of the cell by other exchangers on the basolateral membrane, facing the bloodstream. These are vital for maintaining the intracellular pH.
And what powers all this? It sounds like an energy-intensive process for a duct cell.
It is. The primary driving force comes from pumps maintaining the sodium gradient across the cell membrane. This gradient is then used by other transporters. Plus, potassium channels help maintain the necessary electrical potential. It's a symphony of ion movement.
So the duct cells are active, sophisticated players, not just pipes. Why is all this bicarbonate so important? What's its ultimate role?
The bicarbonate secreted by these duct cells is absolutely crucial. Once it reaches the duodenum, its primary role is to neutralize the highly acidic hydrochloric acid coming from the stomach.
Right, because stomach acid is really strong.
Extremely. Pancreatic enzymes, those powerful ones, are like Goldilocks. They are inactivated at low pH. They need a just right, more alkaline environment.
Okay.
So this bicarbonate provides an optimal pH environment, typically pH 8.0 to 9.0 for proteases, 7.0 for amylase, 7.0 to 9.0 for lipase, allowing these vital enzymes to function at peak efficiency.
Oh.
Without it, digestion would be severely impaired.
That's a master class in digestive chemistry. And how is this whole process regulated? When do the acinar and duct cells get the signal to secrete?
Pancreatic exocrine secretion occurs in two main states: the interdigestive state between meals and the digestive state after eating.
Okay.
During the digestive state, secretion follows phases similar to gastric secretion, almost like a carefully orchestrated performance.
Let's start from the beginning. What's the first phase, even before food touches your lips?
The first is the cephalic phase. It's fascinating because it happens before food enters your stomach.
Just thinking about food.
Exactly. The sight, smell, or even just the thought and taste of food triggers it. This phase accounts for about 20-25% of the daily pancreatic juice secretion.
Wow.
It's triggered by the vagus nerve, your body's main wandering nerve. The primary mediator is acetylcholine, a neurotransmitter, which primarily stimulates acinar cells to secrete their enzymes.
So your pancreas literally salivates for food, a Pavlovian response.
Well, much, yeah. Your body's getting ready for dinner.
What comes next once food actually hits the stomach?
That's the gastric phase, accounting for about 10% of daily production. This phase is mediated by vagovagal reflexes.
Vagovagal.
Long reflexes involving the vagus nerve connecting the stomach and pancreas. They're triggered by the distension of the stomach after you've eaten. Like the cephalic phase, it primarily induces acinar cell enzyme secretion. Think of it as the next level of preparation.
And then the main event, once food reaches the small intestine, I imagine that's where the bulk of the work happens.
Absolutely.
Yeah.
The most important phase, by far, is the intestinal phase. It's responsible for a substantial 65-70% of the total pancreatic juice secretion.
Okay.
This phase is intricately mediated by two key hormones released from the small intestine: secretin and cholecystokinin, or CCK.
Secretin and CCK.
These hormones act as powerful chemical messengers, fine-tuning the pancreatic response.
Let's start with secretin. What triggers it, and what does it tell the pancreas to do?
Secretin is released by specialized S cells in the duodenal mucosa, the lining. Its primary trigger is the acidification of the duodenal lumen as the sitting chyme empties from the stomach.
So the acid itself is the trigger.
Yes. Secretin was actually the first polypeptide hormone ever identified over a century ago.
Wow.
It's the most important mediator of water, bicarbonate, and electrolyte secretion. Its receptors are found exclusively on the basolateral membrane of pancreatic duct cells.
Okay, just the duct cells.
When secretin stimulates these receptors, it increases intracellular signaling, which activates that critical bicarbonate chloride exchanger, ramps up carbonic anhydrase, and boosts CFTR activity. All of this dramatically increases the secretion of bicarbonate-rich fluid to neutralize that stomach acid.
And CCK. What's its role, and what triggers its release?
CCK is released by eye cells, another type of specialized cell in the duodenal mucosa. Its release is triggered by the presence of lipids, proteins, and carbohydrates, the breakdown products of food in the duodenum.
The food itself?
Yeah, these nutrients stimulate factors that induce CCK secretion. While secretin handles the water and bicarbonate, CCK is the main mediator of pancreatic enzyme secretion.
Okay, so CCK for enzymes, secretin for bicarbonate fluid.
Exactly. CCK has several powerful effects. First, it travels through the bloodstream and directly tells acinar cells to release enzymes.
Okay.
Second, it triggers local vagal reflexes, leading to neurotransmitter release that further promotes enzyme release. And third, CCK actually induces relaxation of the sphincter of Oddi, the muscular valve controlling flow into the duodenum, ensuring everything can flow smoothly. What's truly remarkable is the synergy between CCK and secretin. They potentiate each other's effects, creating a highly efficient, orchestrated release to maximize digestion.
It's a beautifully coordinated dance of nerves and hormones, a real masterclass. But as we know, sometimes this elegant system goes awry, and when it does, it can be quite dramatic. Let's move to acute pancreatitis. Acute pancreatitis, or AP. It's a condition that has seen a significant increase in hospital admissions, now over 300,000 annually in the U.S.
That's a huge number.
It is, and while most cases are relatively mild, a significant 10% to 20% can be rapidly progressive, leading to long hospital stays and high morbidity and mortality.
Right. In mild cases, mortality is low, less than 1%. But in severe AP, it can unfortunately skyrocket to between 10% and 50%.
Yeah.
Especially in those who develop multiple organ dysfunction syndrome. MODS. The mortality actually has a distinct pattern. In the first 2 weeks, the early phase, mortality is typically due to MODS. This is caused by an intense, overwhelming inflammatory cascade triggered by the pancreatic inflammation itself.
A systemic overload.
Essentially, yeah, affecting organs like the lungs, kidneys, heart. After 2 weeks, in the late phase, mortality is more often due to septic complications, typically from infected pancreatic necrosis, where the damaged pancreas gets infected.
That's a grim picture. What's actually happening at the cellular level when acute pancreatitis strikes? How does the pancreas start digesting itself?
The core concept of acute pancreatitis is the abnormal activation of pancreatic enzymes inside the acinar cells, where they're supposed to be safely inactive. The exact initial triggers, like gallstones or alcohol, aren't completely understood, but the disastrous events that follow are becoming much clearer.
So the digestive enzymes turn inward. How does that initial internal activation happen?
What's truly remarkable is how quickly things go wrong. Immunological studies show that within just 15 minutes of injury, long before clinical signs or elevated enzymes appear.
15 minutes? That's incredibly fast.
It is. The tiny packets containing inactive enzymes, the zymogen granules, actually merge or come into close contact with lysosomes, which contain degradative enzymes. This colocalization is a critical early step.
Okay.
Research suggests a specific lysosomal enzyme called cathepsin B is key here. It acts like a rogue switch, activating trypsin within these merged organelles.
Cathepsin B.
Once activated, trypsin sets off a catastrophic cascade, inducing leakage of these organelles and releasing even more cathepsin B into the cell. It's this internal runaway cathepsin B that then directly causes acinar cell death, either through apoptosis or destructive necrosis.
Wow.
This insight is so important that studies show if you treat cells with cathepsin B inhibitors or genetically remove it in mice, you can prevent or significantly decrease the severity of pancreatitis.
So it's a very early, very specific internal activation event. What happens after the acinar cells start dying? Does the inflammation escalate?
Once those intraacinar enzymes are activated, they lead to autodigestion of the normal pancreatic tissue, literally breaking it down. This initial insult then triggers a powerful inflammatory response.
Okay.
The damaged acinar cells themselves release a barrage of pro-inflammatory cytokines like chemical alarms such as TNF-I and interleukins IL-1, IL-2, IL-6.
Right.
They also try to release anti-inflammatory mediators like IL-10, attempting to balance it, but often it's too little, too late. While these alarms don't initiate the injury, they dramatically propagate it both locally and systemically.
Spreading the fire.
Exactly. This leads to the recruitment of other inflammatory cells, like neutrophils and macrophages, into the pancreas. These cells then unleash even more cytokines, along with reactive oxygen molecules and other damaging compounds.
That sounds like an escalating, self-perpetuating cycle of damage.
It is. This local inflammatory response severely aggravates the pancreatitis by increasing blood vessel permeability and damaging the microcirculation. In severe cases, this leads to hemorrhage and widespread pancreatic necrosis, where parts of the pancreas actually die.
Necrosis. Tissue death.
Yes. What's more, some of the inflammatory mediators released by neutrophils actually activate more pancreatic enzymes, creating a truly vicious cycle of injury and destruction.
And this vicious cycle can spread beyond the pancreas, right? Leading to that severe organ failure, MODS.
Yes. In about 80–90% of patients, this cascade is self-limited, and they recover without severe complications.
Oh, okay, that's good.
However, in the remaining cases, this cycle persists. In a smaller subset of these severe patients, there's a massive spillover of these inflammatory mediators into the systemic circulation. This systemic inflammation, largely driven by active neutrophils, can cause acute lung injury and ARDS, adult respiratory distress syndrome.
Right, ARD.
Which is frequently seen in severe AP. This intense systemic response is directly responsible for the high mortality in the early phase, due to MODS, where vital organs fail, sometimes quite rapidly.
That paints a very clear, if alarming, picture. So what are the most common things that trigger this inflammatory storm in the first place?
The two dominant culprits for acute pancreatitis are gallstones and excessive ethanol abuse. Together, they account for 70% to 80% of all AP cases.
Gallstones and alcohol, the big two.
Yeah. However, in children, the picture changes significantly. Blunt abdominal trauma and systemic diseases are the two most common causes. Also, it's worth noting, autoimmune and drug-induced pancreatitis should always be considered, especially with rheumatologic conditions or multiple medications.
Let's start with gallstones. How do they cause pancreatitis? Do they just block a duct?
Gallstone pancreatitis is the most common cause in Western countries, about 40% of U.S. cases. It occurs in a small percentage, 3% to 8% of patients with symptomatic gallstone disease, and it's more common in women aged 50-70. The exact mechanism isn't fully pinned down, but two main theories exist. First is the obstructive theory.
It's an obstruction.
Yeah. It suggests injury results from excessive pressure inside the pancreatic duct, caused by juice trying to get out, but blocked by a stone temporarily stuck at the ampulla of Vater, that common opening. Animal studies even suggest this pressure initiates pancreatitis through specific cell signaling.
And the second theory?
The second is the reflux theory. This proposes a stone gets impacted, creating a common channel allowing bile salts to reflux, or flow backward, into the pancreatic duct.
Bile in the pancreas duct, that sounds bad.
It does. Animal models show bile salts can directly cause acinar cell necrosis by increasing intracellular calcium, though this isn't definitively proven in humans. Regardless, gallstones are a clear, potent risk factor.
And alcohol, the other major cause. Why does it cause pancreatitis, especially since only a small percentage of heavy drinkers get it? Seems like there's more to it.
That's a crucial nuance, you're right. Excessive ethanol consumption is the second most common cause worldwide, about 35% of cases, more prevalent in young men. But as you said, only 5–10% of heavy drinkers develop AP.
Right.
This strongly suggests alcohol is more of a cofactor, needing other factors like smoking, which increases the risk almost 5 times for alcohol-induced AP.
Wow, 5 times.
Or an underlying genetic predisposition. Alcohol has a multifaceted direct assault on pancreatic cells. It triggers pro-inflammatory pathways, upregulating key inflammatory signals. It causes inappropriate enzyme release from the wrong side of acinar cells.
Internal chaos. Enzymes going rogue.
It is. Alcohol also leads to increased autophagy, cellular self-digestion, possibly due to dysregulation of catexin L and B. There's increased oxidative stress, mitochondrial dysfunction.
Energy problem.
Yeah. It can activate pancreatic stellate cells, causing scarring. It impairs the pancreas's ability to repair itself, and critically, it shifts cell death from controlled apoptosis towards destructive necrosis. It's a comprehensive assault.
Beyond gallstones and alcohol, are there other physical obstructions that can trigger it?
Yes, anything impeding the flow of pancreatic juice.
Yeah.
Acute pancreatitis has been described with pancreatic tumors, although cancer itself rarely causes AP as its presenting symptom.
Okay.
Parasitic infections like Ascaris lumbricoides, a roundworm, can cause obstruction, and congenital defects like annular pancreas forming that ring.
And pancreas divisum, which you mentioned earlier.
Correct. While it affects 10% of the population, only 5–10% of those individuals face a lifetime risk of AP. This is due to relative outflow obstruction through the smaller minor papilla, causing back pressure.
Okay.
For symptomatic patients, a procedure called ERCP with minor papillotomy, widening the opening and stenting, can sometimes help improve drainage.
Speaking of ERCP, it can also cause pancreatitis, right? That tricky paradox.
Unfortunately, yes. ERCP-induced pancreatitis is the most common complication. Up to 5% of patients, maybe 15% in high-risk ones.
Why does it happen?
It's more common in females, younger patients, prior history, therapeutic versus diagnostic procedures, multiple cannulation attempts, sphincter of Oddi dysfunction, several factors. While most cases are mild, it's one instance where primary prevention is possible.
How do you prevent it?
We advocate for ERCP only when absolutely necessary, often using non-invasive MRCP for diagnosis. Pharmacologically, indomethacin, an anti-inflammatory, has gained traction. And technically, using pancreatic stents and minimal pressure helps reduce risk.
What about common medications? Can they induce it?
Yes, drug-induced pancreatitis accounts for up to 2% of AP cases. It's a long list, but common culprits include certain antibiotics like sulfonamides, metronidazole, or thermycin, tetracyclines, also statins, immunosuppressants like azathioprine, some HIV drugs.
Wow, quite a few. Are there any metabolic conditions that trigger it?
Yes, hypertriglyceridemia, very high blood fats, and hypercalcemia, high calcium, are notable. With hypertriglyceridemia, direct injury from triglyceride breakdown products is thought responsible. It's more common with certain genetic predispositions and suspected if levels exceed the 1,000 mg/dL, confirmed over 2,000.
Okay.
Interestingly, high triglycerides secondary to things like hypothyroidism or diabetes usually don't induce AP. It's the very high primary levels.
And high calcium.
Hypercalcemia is postulated to induce injury by activating trypsinogen and causing calcium precipitation in the ducts, leading to obstruction, seen in about 1.5–13% of patients with primary hyperparathyroidism.
And any other miscellaneous, less common causes?
Indeed. Blunt and penetrating abdominal trauma, though rare causes. Prolonged low blood pressure during surgery or excessive pancreatic manipulation. Pancreatic ischemia after procedures like splenic artery embolization. And interestingly, scorpion venom stings in some regions, and even perforated duodenal ulcers have been implicated. It's a surprisingly diverse list.
It seems like the pancreas is vulnerable from many angles. When a patient presents with AP, what are the characteristic signs and symptoms? What makes a doctor suspect it?
The cardinal symptom is severe epigastric or periumbilical pain, upper middle, or around the belly button, which frequently radiates straight through to the back.
Radiating to the back, that's classic.
It is, and this pain is typically constant and unremitting. If the pain spontaneously disappears or significantly decreases, it should actually prompt consideration of an alternative diagnosis.
Okay, so constant pain is key. What else often comes with it?
Up to 90% of patients experience nausea or vomiting. Importantly, unlike some other abdominal conditions, this vomiting usually does not relieve the pain.
Doesn't help the pain. Okay.
Beyond the pain and GI symptoms, patients often show systemic signs: dehydration, poor skin turgor, rapid heart rate, low blood pressure, dry mucous membranes. In severe cases or older patients, changes in mental status can also develop.
What would a doctor find during a physical exam? Is it always obvious?
It can vary significantly. In mild pancreatitis, the abdominal exam might be normal or show only mild upper abdominal tenderness.
Okay.
However, in severe pancreatitis, you'd see significant abdominal distension, generalized rebound tenderness, pain on release, and even abdominal rigidity, indicating irritation of the abdominal lining.
Right.
It's worth noting the patient's pain intensity doesn't always correlate directly with the exam findings or the actual inflammation.
Are there any very rare but distinctive physical signs that point to severe AP, something visually striking?
Yes, two striking, albeit rare, signs indicate severe retroperitoneal bleeding with necrotizing pancreatitis. Gray-Turner sign bruising in the flank,
Okay.
and Cullen sign bruising around the belly button. Both are strong indicators of severe, often hemorrhagic pancreatitis.
Wow.
Patients might also present with jaundice yellowing, if there's a gallstone obstructing the bile duct, or if swelling in the pancreatic head compresses the duct. And dullness to percussion or decreased breathing sounds, especially on the left, can suggest a pleural effusion, fluid in the chest cavity.
Those are very specific, almost cinematic clues. How is acute pancreatitis definitively diagnosed? What's the gold standard or criteria?
For a definitive diagnosis, international consensus criteria require 2 out of 3 key features.
2 out of 3.
First, characteristic abdominal pain acute onset, persistent severe upper abdomen, often radiating to the back.
Got it.
Second, a serum amylase or lipase level 3 times or higher than the upper limit of normal.
Enzymes up high.
And third, characteristic findings of pancreatitis on imaging.
So those enzyme levels are key. Is one better than the other, amylase versus lipase?
Lipase is generally preferred, especially if the patient presents more than 24–48 hours after onset.
Why lipase?
Amylase has a shorter half-life, normalizing within 3 to 5 days. Lipase stays elevated longer, 8–14 days, making it more sensitive later on. Lipase is also more specific. Amylase can be elevated in other conditions, ulcers, ischemia, salivary gland issues leading to false positives, so lipase is usually more reliable.
What other lab findings might support the diagnosis?
Patients often have hyperglycemia, high blood sugar, and leukocytosis, high white blood cell count, indicating inflammation.
Okay.
Elevated liver enzymes can also be present. What's particularly useful is that a significant rise in ALT, choline aminotransferase, alongside high pancreatic enzymes, has a 95% positive predictive value for acute biliary pancreatitis.
Strongly suggests gallstones.
Exactly.
And imaging. Not always required for diagnosis, but crucial for understanding extent and complications.
Right. Imaging isn't always needed initially if pain and enzymes meet criteria, but it's invaluable for assessing severity or finding a cause. Simple abdominal x-rays aren't diagnostic for AP, but help rule out other things like a perforated ulcer. You might see nonspecific signs like air fluid levels from a sluggish bowel.
What about ultrasound? Good for gallstones.
Ultrasound is almost always ordered, primarily for its high sensitivity, 95% in diagnosing gallstones. Its view of the pancreas itself is often limited by fat and gas. However, combined with elevated liver and pancreatic enzymes, gallstones on ultrasound give very high sensitivity, 97%, and specificity, 100%, for diagnosing acute biliary pancreatitis.
So ultrasound for gallstones. What's the best imaging for the pancreas itself and severity?
Contrast-enhanced CT is currently considered the best, especially multi-detector CT.
When do you do a CT?
Indications include diagnostic uncertainty, confirming severity based on clinical signs, failure to respond to treatment, or clinical deterioration. The portal venous phase, about 65-70 seconds after contrast, is best for evaluating tissue viability, inflammation, and fluid collections. A non-contrast CT can also be useful, especially if kidneys are an issue.
And MRI, used acutely.
Abdominal MRI is useful for evaluating necrosis, inflammation, fluid, and avoids radiation. But cost, availability, and patient stability limit its acute phase use.
Okay, what about MRCP?
MRCP is generally not indicated in acute AP, but it's crucial for evaluating unexplained or recurrent pancreatitis. It gives non-invasive, complete visualization of biliary and pancreatic ducts.
Can make the ducts show up better.
Yes, injecting secretin before imaging stimulates juice secretion, distending the duct. Pain with secretin stimulation can even help confirm an uncertain cause of pain, like devisum or a small tumor.
And finally, endoscopic ultrasound, EUS.
In gallstone pancreatitis, EUS is crucial for evaluating persistent bile duct stones. Routine ERCP is often avoided as it can worsen symptoms and often finds no stone. EUS is highly sensitive for bile duct stones without worsening pancreatitis. If EUS confirms obstruction, then ERCP can be used therapeutically.
That's a comprehensive diagnostic toolkit. Once AP is diagnosed, how do we assess severity? How do we know if it's mild or life-threatening?
Assessing severity is critical for guiding treatment and predicting outcomes. One of the earliest systems, Ranson criteria from 1974, uses 11 parameters at admission and 48 hours.
Ranson criteria.
3 or more positive criteria define severe pancreatitis. The more criteria, the higher the mortality.
But it takes 48 hours.
That's its main disadvantage. Can't predict severity fully at admission. It has low positive predictive value, 50%, but high negative predictive value, 90%. So it's good at ruling out severe disease, more for prognosis or confirming mild cases.
So more for ruling out severe cases. Are there other scoring systems maybe usable earlier?
Yes, the Apache 2 score acute physiology and chronic health evaluation. It's a general severity measure based on age, health, and 12 physiological measurements.
Okay.
A score of 8 or higher defines severe AP. Advantage, usable anytime. Disadvantage, complex, not AP specific, age bias.
What about using the CT scan itself?
Yes, the CT Severity Index, or CTSI, correlates specific CT findings, inflammation degree, necrosis percentage with outcome, especially useful later on.
Are there faster, simpler methods doctors use right away?
Indeed. Many societies now recommend the Systemic Inflammatory Response Syndrome, or SIRS, scoring system. It's fast, inexpensive, reliable.
SIRS, what are the criteria?
Simple. Temperature too high or low, heart rate 90, rapid breathing or low CO2, white blood cell count too high or low, or too many immature cells.
Okay.
What's compelling is the strong correlation between persistent SIRS and mortality. 25% for persistent SIRS, 8% for transient, 0% for never meeting criteria. Excellent real-time predictor.
And the Atlanta classification, that categorizes cases more broadly.
Yes. The 1992 definition links severe AP to local complications, necrosis, abscess, pseudocyst, or organ failure. The 2012 update created a 3-tiered grading: mild, no organ dysfunction complications; moderate, organ failure 48 hour and or local systemic complications; and severe, organ failure 48 hour. As severity increases, so do morbidity and mortality. A crucial clinical guide.
Are there any biochemical markers that indicate severity, something in the blood?
C-reactive protein, CRP, an inflammatory marker, typically peaks 48-72 hours after onset and correlates with severity. 150 millimL suggests severe AP limitation, not useful at admission. Other markers like procalcitonin, IL-6, IL-1, elastase also correlate, but cost and availability often limit routine use. Comparing these, SIRS remains perhaps the most accessible and rapidly actionable indicator.
So once severity is gauged, what's the fundamental approach to treatment? The immediate cornerstones.
Regardless of cause or initial severity, the cornerstones are aggressive fluid resuscitation with isotonic crystalloid solution, robust pain control, and early nutrition.
Fluids, pain control, nutrition. Got it.
Fluid rate needs to be highly individualized based on age, comorbidities, vitals, mental status, kidney function.
Okay.
For non-responders or those with significant organ issues, more invasive monitoring with central lines and urinary catheters is often needed. While debated, Ringer's lactate is sometimes preferred over saline, possibly reducing systemic inflammation.
Beyond fluids, what about pain and breathing? Pain can be awful.
Effective pain control is essential. Narcotics are usually preferred, morphine is common. The old concern about morphine affecting the sphincter of Oddi.
Yeah.
Current evidence shows no negative impact on AP outcome. And due to common acute lung injury causing low oxygen, continuous pulse oximetry and supplementary oxygen are vital to keep saturation to 95%.
Nutrition is often a challenge, right? Guts inflamed, nausea.
It's vital. Oral feeding can be impossible due to ileus, sluggish bowels, severe pain, or intubation. Plus, 20% of severe AP patients get recurrent pain when restarting oral feeding.
So what are the options?
Enteral feeding into the gut and total parenteral nutrition. TPN intravenous feeding. Enteral is strongly favored.
Why enteral?
While no mortality difference, enteral nutrition has significantly fewer infectious complications and reduces the need for pancreatic surgery. TPN carries risks: gut atrophy, bacterial overgrowth, line infections, metabolic issues like high blood sugar.
Okay.
So whenever possible, enteral via a nasovaginal tube past the stomach is preferred, or even nasogastric if no outlet obstruction.
I remember prophylactic antibiotics used to be common for severe AP. Has that changed?
Dramatically shifted. In the 70s, they were advocated due to sepsis concerns. However, recent meta-analyses and systematic reviews clearly show prophylactic antibiotics do not decrease surgical intervention, infected necrosis, or mortality.
Really? No benefit?
No benefit shown. In fact, they're associated with increased risk of resistant bacteria and fungal infections.
Wow.
Current recommendation: antibiotics only if there's a pre-existing infection or radiographic suspicion of infected fluid collections. Like seeing gas or clear inflammation, it's targeted now.
What about special considerations like ERCP? You said it can cause AP, so is it still used?
Early ERCP, sometimes with sphincterotomy, was initially advocated based on the obstructive theory.
Right, to relieve blockage.
But multiple randomized trials have since shown routine early ERCP is not supported for acute biliary pancreatitis, regardless of severity. The obstruction is usually transient, resolving spontaneously. Based on guidelines, ERCP is now indicated only for patients with cholangitis bile duct infection or persistent bile duct obstruction confirmed by other imaging like EUS. It can also be a safe alternative to prevent recurrence in older poor health patients not fit for gallbladder surgery.
And removing the gallbladder, since gallstones are so common, when should that happen?
Laparoscopic cholecystectomy is crucial for all patients with mild acute biliary pancreatitis, except the very elderly or frail. Without it, about 30% recur.
Okay.
Studies show doing it early, during the initial ischem, is safe and reduces recurrence. Before surgery, we check for remaining bile duct stones.
What about for severe pancreatitis? Same timing.
No, for severe AP, early surgery can increase complications. Current recommendations suggest delaying cholecystectomy for at least 6 weeks to let inflammation subside, significantly decreasing surgical risks.
Clear distinction based on severity. Even with the best treatment, complications arise. What are the most common and dangerous ones?
Acute pancreatitis can lead to a cascade of complications, mainly fluid collections and necrosis tissue death. The current classification helps distinguish them.
Okay.
Acute peripancreatic fluid collections are simple, non-walled-off pockets 4 weeks old. After 4 weeks, they're pseudocysts with a fibrous wall.
Pseudocysts.
For necrotizing pancreatitis, a collection 4 weeks old is an acute necrotic collection, A and C. After 4 weeks, it's walled-off necrosis, 111.
Okay, these fluid collections, unlike true cysts, aren't lined by epithelium. Most are reabsorbed spontaneously. Initial treatment is supportive.
But these collections can get infected, correct? That sounds dangerous.
Yes, a major concern. Suspecting infection is challenging because fever, high white count, pain can also be present in sterile AP due to SIRS.
Right.
However, if imaging shows gas within a collection, that's highly suggestive. If a patient suddenly worsens or fails to improve after 10-14 days, suspect infection. CT-guided fluid sampling can confirm it.
And if infected, drainage percutaneous through skin or endoscopic via gut, plus targeted IV antibiotics. Antibiotics that penetrate necrosis include carbapenems, certain quinolones, metronidazole, high-dose cephalosporins.
And the most severe complication, pancreatic necrosis itself. What is it and why so deadly?
Pancreatic necrosis is non-viable, dead pancreatic parenchyma or fat. Contrast-enhanced CT is most reliable, showing areas that don't light up due to lack of blood flow.
Okay.
Up to 20% of AP patients develop these acute necrotic collections. Critically, necrosis is found in up to 80% of autopsies of patients who died from AP, highlighting its lethal potential.
What's the main risk with necrosis? Infection.
The risk directly correlates with the amount of necrosis. 22% risk if 30% necrotic, 37% for 30-50%, up to 46% if 70% involved.
Wow. How does it get infected?
Primarily bacterial translocation. Gut bacteria like E. coli, Klebsiella cross the damaged intestinal barrier and invade the dead tissue. Less commonly, distant infections or procedure contamination.
How do you suspect infected necrosis clinically if signs overlap?
Prolonged fever, high white count, progressive deterioration, sepsis or organ failure 7 days after onset. Error on CT confirms, but it's rare. If suspicious but unclear, fine needle aspiration, FNA, with gram stain culture helps. But negative cultures don't rule it out. Many still have infection.
What's the treatment for necrosis, sterile versus infected? Has it changed?
For sterile necrosis, intervention generally isn't needed unless persistent pain, failure of conservative management, or symptomatic obstruction. Crucially, if intervention is needed, delay as long as possible, ideally 4+ weeks, to allow walled-off necrosis, one, to form, makes intervention safer.
Okay, wait for it to wall off. And for infected necrosis?
Clear indication for intervention if clinically deteriorating, but again, delaying to allow one formation is preferred if possible. Once infection is shown, AV antibiotics, carbapenems, often first line, due to penetration in spectrum.
So the trend is away from immediate open surgery?
Dramatically. Historically, extensive surgical debridement necrosectomy was done, often open, very high mortality, 25-30%, especially if done early, up to 75% at 14 days. Modern approaches shifted. The step-up approach, Dutch Pancreatitis Study Group, initial percutaneous drainage, followed by minimally invasive video-assisted retroperitoneal debridement if needed, showed better long-term outcomes than open necrosectomy.
Okay.
More recently, endoscopic management scope through stomach duodenum to drain-remove tissue compared to step-up. Non-inferior mortality, but fewer fistulas, shorter stay, lower cost.
So endoscopy first now.
Current practice often favors endoscopic or percutaneous management first. If these fail, minimally invasive operation is more straightforward. Physiologic and nutritional support remain paramount throughout.
What about pancreatic pseudocysts, distinct from necrotic collections, common after AP?
Pseudocysts occur in 5-15% of patients with peripancreatic fluid collections after AP. By definition, a pseudocyst has a capsule of collagen granulation tissue, not epithelial lining. It takes 4 to 8 weeks to develop.
Okay. Do they cause symptoms?
About 50% do. Persistent pain, early satiety, nausea, weight loss, elevated enzymes. Diagnosis is confirmed by CT-MRI. EUS with FNA is useful if diagnosis is unclear. High amylase, no mucin, low CEA helps differentiate from cancerous cysts.
How are pseudocysts treated? Always surgery?
Not at all. Observation for asymptomatic patients, especially at 4 centimeters in the tail, no duct obstruction communication. Up to 70% spontaneously regress.
Okay.
Invasive therapies for symptomatic patients or if differentiating from neoplasm is hard. Modern evidence strongly favors transgastric transduodenal endoscopic drainage for pseudocysts close 1 centimeter to stomach duodenum.
Drain it right into the gut.
Exactly. Transpapillary drainage for communicating pseudocysts, endoscopic dilation stent for associated duct strictures. A randomized trial showed endoscopic drainage equal efficacy to operative cystogastrostomy, but quicker QOL improvement, lower cost for simple pseudocysts.
So when is surgery needed for pseudocysts?
Generally reserved, if not treatable endoscopically, or if endoscopic treatment failed. Procedure depends on location. Cystogastrostomy, cystoduodenostomy, duodenum, Roux-en-Y, cystogenostomy, not close to either. High immediate success, 90%, but recurrence up to 12%.
Okay.
Complications: bleeding, fistula, obstruction, rupture, infection. Percutaneous drainage, usually only for septic infected pseudocysts due to high external fistula risk otherwise.
Speaking of fistulas, pancreaticopleural fistulas and pancreatic ascites. Fluid leaking places it shouldn't.
They are indeed. Pancreatic ascites is rare but severe. complete duct disruption, massive pancreatic fluid in abdomen, suspect with AP, distension, free fluid. Diagnosed by paracentesis showing high enzymes.
Good for me.
Abdominal drainage plus endoscopic pancreatic stent across disruption. Surgical resection if that fails.
And pancreatico-pleural fistula.
Also rare, posterior duct disruption tracks up into pleural space, fluid around lungs. Symptoms, dyspnea, pain, cough. Diagnosis, chest x-ray, thoracentesis, CT, pleural fluid anomalies, 50,000. More common after alcoholic AP, often with pseudocysts.
Treatment for that.
Chest drainage, nutritional support, octreotide. Up to 60% respond, persistent drainage, endoscopic sphincterotomy stent. Surgery if measures fail.
It sounds like vascular complications could also be a major concern near major vessels.
They are, though rare. Arterial pseudoaneurysms can occur, false aneurysms. Splenic artery, most common. Thought enzymes like elastase damage vessels, spontaneous rupture, massive bleeding.
Treatment.
Arterial embolization is possible. Ligation for refractory cases. High mortality, 28 to 56%.
And venous complications like clots.
Inflammation can cause thrombosis. Splenic vein, most affected, can extend to portal system. Imaging, enlarged spleen, gastric varices, vein occlusion.
Treatment.
Thrombolytic, sometimes acutely. Most managed conservatively. Anticoagulation not proven to improve recanalization. Splenectomy for recurrent GI bleeding from venous hypertension.
Finally, pancreatic cutaneous fistula, leak to the skin.
Low frequency, 0.4% after AP alone, but increases with complications. 4.5% with pseudocysts, 40% after surgical debridement for infected necrosis. Most treated conservatively, allowing healing over time.
That's a lot to contend with acutely. But what about the long haul? When pancreatitis becomes chronic, scarring the gland.
Unlike acute pancreatitis, the hallmark of chronic pancreatitis, CP, is persistent inflammation and irreversible fibrosis leading to progressive atrophy and scarring.
Irreversible scarring.
Yeah, this fundamentally alters the gland, resulting in chronic, often debilitating, pain and both endocrine and exocrine insufficiency. Severely diminishes quality of life. Affects 310 per 100,000 persons.
So, structural and functional breakdown, slow destruction. What are the main risk factors for CP beyond those for acute?
Causes vary. In urban hospitals, heavy alcohol consumption is still most common, 70-80% of cases.
Alcohol again? Yep.
Rarer causes, 10%. Chronic duct obstruction, stones, strictures, trauma, pancreas stavism, cystic dystrophy, hyperparathyroidism, high calcium, hypertriglyceridemia, autoimmune, tropical, hereditary pancreatitis.
Okay.
In specialized referral centers, hereditary chronic autoimmune seen more often. And in 10-20% of patients, no clear cause is found labeled idiopathic.
Let's delve into alcohol again. You said only a small percentage of heavy drinkers get AP. Same for CP. And how does alcohol cause long-term scarring?
Yes, the nuance holds. Only 3-7% of heavy drinkers develop CP, strongly suggesting alcohol is a cofactor, needing other factors like genetics or environment.
Okay.
Alcohol has multiple detrimental effects. It increases protein concentration in pancreatic juice, promotes secretion of certain proteins. This leads to protein precipitation, forming plugs that calcify into stones inside the duct.
Stones blocking the ducts.
Exactly. Obstruction traps enzymes, predisposing acinar cells to autodigestion.
So obstruction plus direct cell injury, a double whammy.
Exactly. Beyond obstruction, alcohol metabolism produces toxic compounds, fatty acid ethyl esters, reactive oxygen species, free radicals. These cause fragility in organelles, leading to abnormal enzyme activation inside cells. Acetaldehyde also causes direct acinar injury.
Wow.
Chronic alcohol enhances inflammatory pathways, decreases microcirculation, increases intracellular calcium, all contributing to sustained damage and inflammation, driving the chronic process.
You mentioned pancreatic stellate cells, PSCs. How do they factor into chronic pancreatitis? Do they cause the scarring?
Their identification in the late 90s was a major breakthrough. PSCs are specialized quiescent fibroblasts at the base of acinar cells. Once stimulated, they transform into activated myofibroblasts.
Myofibroblasts.
These are the primary cells responsible for synthesizing extracellular matrix proteins, collagen, 33, fibronectin, laminin, the very building blocks of fibrosis, the scarring that characterizes CP.
So they're truly responsible for the progressive scarring. What activates them in CP?
Chronic necroinflammation, often from ethanol, releases inflammatory mediators, growth factors, interleukins. These activate PSCs, dramatically increasing collagen synthesis. It postulated chronic inflammation from alcohol as a major driver.
Okay.
Interestingly, alcohol and its metabolites can directly activate PSCs too, bypassing the need for initial inflammation.
Are there any novel therapies targeting these scarring cells?
Yes. Preclinical studies are exploring therapies to inhibit PSC activation. Antioxidants, certain blood pressure meds, Vitamin A derivatives show promise, exciting avenues for future treatments that could potentially halt or slow fibrosis.
What about smoking? Does it contribute to CP?
Epidemiologic studies clearly show smoking significantly increases risk of alcohol-induced CP. Active smokers tend to develop CP younger, have increased calcifications and diabetes compared to non-smokers, another powerful cofactor.
And genetics, specific gene mutations linked to CP.
Absolutely. Pancreatic enzyme activation is strictly controlled. Mutations in regulatory proteins increase CP risk. For instance, mutations in cationic trypsinogen gene, PRSS1, common in hereditary CP,
PRSS1.
regulates trypsinogen production. Mutations linked to premature intra-acinar activation, initiating the process. Uncommon in other CP forms, though.
And SPINK1, the protector. Do mutations cause CP?
SPK1 inhibits premature trypsinogen activation. Mutations found in 1–2% healthy people, much higher than CP prevalence. So, hypothesis is mutations aren't enough alone, but act as a risk amplifier. Lower the threshold, influence severity. More prevalent in alcoholic hereditary idiopathic CP.
What about CFTR, the cystic fibrosis gene, linked to CP too?
Yes, CFTR mutations regulating bicarbonate techchloride are a significant factor. Impair water bicarbonate secretion, decrease juice volume, increase enzyme concentration, blockages, inflammation.
Okay.
Homozygous MyCF. Heterozygous predisposed to exocrine insufficiency CP. Higher prevalence in alcoholic idiopathic hereditary CP. Similarly, mutations in human chymotrypsin C gene linked to CP, it normally degrades trypsinogen.
So a complex genetic picture, does this open new avenues?
It does. Well, understanding has been trypsin-centric. Animal studies in trypsin knockout mice suggest chronic stimuli can induce CP without trypsin. Yeah, indicating alternative trypsin-independent pathways might exist. Elucidating these could lead to novel therapeutics. Plus, for the 10–20% idiopathic cases, hope is future genetics will identify those at highest risk, enabling earlier intervention.
Are there distinct forms of CP beyond the general types? Hashtag 4.2 distinctive forms of chronic pancreatitis?
Yes, two notable distinctive forms are autoimmune pancreatitis, AIP, and tropical pancreatitis. AIP is a chronic inflammatory disorder caused by an overactive immune system. Two histologic variants.
Okay.
Type 1 AIP is the pancreatic manifestation of a broader disorder called IgG4-related disease, characterized by dense, distinct inflammation scarring patterns. Most common type.
And type 2?
Type 2 AIP is pancreatic-specific, not linked to IgG4 disease.
Right.
Pancreas is infiltrated by inflammatory cells destroying duct epithelium. AIP is more common in men, 80% over 50. Challenging because patients can present mimicking pancreatic cancer, jaundice, AP. Most present with chronic abdominal discomfort, elevated enzymes.
And tropical pancreatitis, geographic?
It is. Uncommon in U.S., prevalent in tropical areas like India. Pathophysiology not fully delineated associated with cassava ingestion, and notably SPNK1 mutations, found in almost half. Highlights interplay of genetics and environment.
Once CP is diagnosed, what are the primary clinical manifestations? How do patients experience this long battle?
The primary, most debilitating manifestation is pain. Initially, may be triggered by eating, but over time, intensity, frequency, duration increase, becoming chronic, almost constant.
Colorful.
Significantly impacts quality of life, decreased intake, activity interference, often narcotic dependence. Nausea, vomiting may appear later as digestion is severely impaired.
And the pancreas's ability to digest food, does that decrease?
That's pancreatic exocrine insufficiency. Chronic inflammation fibrosis progressively decrease acinar cell number function. Symptoms like steatorrhea, fatty stools, diarrhea, malabsorption typically start when 90% gland dysfunctional.
90%. Wow.
Severe cases. Fat-soluble vitamin deficiencies, bleeding, osteopenia, osteoporosis, affects 80–90% of long-standing cases.
So impacts digestion significantly. What about blood sugar? Diabetes.
Chronic pancreatitis also affects islet cells. So 40–80% develop clinical diabetes mellitus, typically years after onset.
Okay.
Crucially, this type is distinct from type 12. Deficiency of both insulin and glucagon makes glucose control particularly challenging, higher risk of severe hypoglycemia, low blood sugar, needs management by an experienced endocrinologist.
Are there other complications from chronic inflammation?
Yes. Jaundice or cholangitis, bile duct inflammation, in 5–10% due to scarring and head compressing common bile duct. Extensive scarring can obstruct duodenum, severe nausea, vomiting, pain, rarely upper GI bleeding secondary to portal splenic vein thrombosis.
A truly debilitating condition. How do you definitively diagnose CP, especially early on?
Cross-sectional imaging is crucial, though a standardized approach is evolving. CT is very important. Common findings. Dilated pancreatic duct, 68%. Parenchymal atrophy, 54%. Calcification stones, 50%. Other signs. Fluid, focal enlargement, biliary dilation, irregular contour. Good sensitivity, 56 to 95%, and specificity, 85 to 100%. Useful for complications. Duct disruption, pseudocysts, thrombosis, pseudoaneurysms.
What about MRI as an alternative?
Reliable alternative, avoids radiation. Lower sensitivity for calcifications, but good for subtle chronic inflammation signs. Intensity changes, atrophy, irregularities. MRCP with secretin useful for intraductal strictures, duct disruption, standardization efforts ongoing.
ERCP used to be gold standard, right? Role changed.
Significantly. Historically gold standard, now primarily therapeutic, reserved if other tests fail or contraindicated. Used for treating duct complications amenable to endoscopy, strictures, stones, pseudocysts, fistulas.
And EUS, endoscopic ultrasound. How accurate for early subtle changes?
The US has emerged as most accurate for early minimal change disease, uses Rosemont criteria.
Rosemont criteria.
Look for parenchymal features, bright spots, honeycombing, and ductal features. Main duct stones, most predictive, irregular contour, dilated side branches, main duct dilation. Positive Rosemont criteria predictive of histologic CP. But normal Rosemont has poor negative predictive value. 55% still have CP histologically. EUS-guided biopsies not currently supported for diagnosis histology can be patchy.
So EUS for subtle changes, not biopsy. What about functional tests, assessing how well it works?
For exocrine insufficiency, fecal elastase 1 level is preferred non-invasive study. Quantifies fecal elastase 1.
How does that work?
200 big normal, 100, 200 mild moderate insufficiency, 100 severe insufficiency. Another test, fecal fat estimation. Measures stool fat after controlled fat intake. 70-day confirmed steatorrhea, fat malabsorption.
So we can diagnose it. How do we manage this chronic, debilitating condition? Requires a complex strategy.
Main goal, palliation of symptoms and removal of active predisposing factors. Optimal treatment absolutely requires a coordinated, multidisciplinary team following a structured plan.
Tier approach. Makes sense.
Patient counseling is critical. Current evidence suggests CP is largely irreversible once established, but progression can often be delayed if predisposing conditions eradicated.
Like stopping drinking and smoking.
Exactly. Strongly encouraged. Treat hypertriglyceridemia. Low-fat diet may benefit some.
Pain is central. How is it managed?
Stepped approach. NSAIDs first line. Tramadol for moderate severe. Potent long-acting narcotics for severe non-responsive pain.
But addiction is a risk with narcotics.
Absolutely. Cannot be overemphasized. Need adjuvant measures. Pain specialists, neuropsychologists to prevent addiction, depression, preserve quality of life. Alternative meds. Certain antidepressants, gabapentin, nerve pain meds. Randomized trials show non-narcotics can reduce pain and opioid need.
What about nerve blocks?
For unrelenting pain, celiac neurolysis injecting anesthetic alcohol into celiac nerve plexus can be tried. Intraoperative or ESCT guided. Reported 80% pain relief.
What about exocrine insufficiency, the digestion problem?
Pancreatic enzyme replacement therapy, PERR, is key. For fatty stools, diarrhea, malabsorption, generally need high lipase dose, 90,000 USP units meal.
Okay.
Give with proton pump inhibitors, PPIs, to reduce stomach acid, improving enzyme effectiveness. Therapeutic trials should last at least 6 weeks.
And endocrine insufficiency, the diabetes.
Management by an endocrinologist is paramount. CP-induced diabetes involves deficiency of both insulin and glucagon. Higher risk of severe hypoglycemia, needs specialized care.
When is interventional therapy like endoscopy considered?
ERCP is primary modality for symptomatic pancreatic duct obstruction dilation, stent placement. Crucial caveat, must rule out pancreatic cancer first, CT, MRCP, US. Surgical resection if malignancy concern.
Okay.
Endoscopic stone extraction for pain dilation due to stones. ESWL, shockwave lithotripsy, plus ERCP for large impacted stones, varying success. Stenting may help. For biliary obstruction, surgical bypass best long-term. Temporarily plastic stents for cholangitis or malnourished patients pre-surgery.
So if medical endoscopic treatments fail or cancer concern, surgery comes in. Indications.
Intractable pain, biliary pancreatic duct obstruction, duodenal obstruction, pseudocysts, pseudoaneurysm, inability to rule out malignancy. Procedure choice depends on symptoms and duct dilation. Large duct disease, 7 mm dilated, decompressing procedure. Small duct disease, non-dilated, resectional procedure.
Let's start with large duct disease and decompression. Main idea.
Dilated duct, chain of lakes, intractable pain. Best treated with side-to-side Rosenweif pancreatic osteogenestomy. Modified quistolateral pancreatic osteogenestomy.
Okay, the quisto.
Open duct interiorly, unroof it, rule out malignancy, extract stones. Connect Rosenweif loop of jejunum for drainage, main advantage. Parenchymal conservation, preserving function. Pain palliation 80% but 30% recurrence, 3 to 5 years. Doesn't modify natural history. Recurrence factors. continued smoking alcohol, incomplete decompression, and anastomosis length.
And the Frey procedure, how does it compare?
Described 1987, similar to Puesto, but anterior head also resected, leaving 1 centimeter rim. Alternative for benign head stricture with severe inflation scarring or portal hypertension. Showed excellent pain control, 62% free, 95% satisfactory. Disadvantage, parenchyma removal, 34% developed insufficiency.
So those are for dilated ducts. What about small duct disease?
Resectional procedures usually needed. Single stricture stone, pancreaticoduodenectomy, Whipple, or distal pancreatectomy. Contraindicated if multiple obstructions. Disadvantage, removes normal parenchyma insufficiency. Can be ameliorated with islet autotransplantation.
And if there's a focal inflammatory mass without duct dilation, worrying for cancer.
Indeed worrisome. CP is risk factor for PDAC. Finding focal mass always concerning. Resection recommended for surgical candidates after ruling out malignancy. Options: Whipple or duodenum-preserving head resection, a Beggar procedure. Beggar aims to preserve foregut anatomy function. RCTs show equivalent symptomatic relief.
What if the entire gland is diffusely involved, no duct dilation, pain is main issue?
Total pancreatectomy, most effective for pain, but invariably causes diabetes mellitus, and that this type is very difficult to manage. High hypoglycemia risk, lack of insulin and glucagon.
Trade-off. Pain relief for challenging diabetes. Anything to mitigate that.
Islet autotransplantation. University of Minnesota, 1977. Harvest islet cells from resected pancreas, transplant back, usually liver, to prevent surgically induced diabetes.
Does it work?
Outcomes: 13 insulin independent, 13 intermittent, 13 dependent, 90% pain relief, 50% off narcotics. Controversial cost facilities. He's highly coordinated multidisciplinary team, particularly effective in pediatric patients with genetic predisposition.
Truly cutting edge. Beyond general procedures, how are specific CP complications managed surgically?
Biliary strictures. Chronic scarring in head compresses bile duct, 5-10% patients, appears long, symmetrical narrowing, cholangitis, 40 fluids, antibiotics, temp stents. If malignancy can't be excluded, Whipple, otherwise. Rule 1, hepatico-pseudocystomy bypass.
Duodenal obstruction.
Duodenal stenosis, 1.2% CP patients. Pain, nausea, vomiting, weight loss. Rule out other causes.
Malnourished.
For dehydration, nutrition, NG tube, permanent treatment. Gastrojejunectomy bypass.
And pseudocysts in CP, treated differently than in acute.
More frequent in CP, 30-40%. Only 10% spontaneously regress, often persistent duct obstruction. Indications same, symptoms, complications. Endoscopic versus surgical drainage options similar to AP. EUS guided drainage benefits from improved vascular visualization.
That really covers the long battle of chronic pancreatitis. Now let's pivot to something perhaps most feared. Neoplasms, particularly pancreatic cancer.
Pancreatic neoplasms, specifically cystic ones, are increasingly recognized, second only to adenocarcinoma. Complex treatment algorithms, evolving international guidelines, Sendai 2006, evolving, broadly distinguished by features like patient demographics, imaging, duct communication, cyst fluid analysis.
Let's start with serous cystic neoplasms, SCNs, characteristics.
Predilection for pancreatic head, older patients, vague abdominal pain, less common weight loss, jaundice.
Right.
Grossly, large, well circumscribed, microscopically multiloculated, glycogen-rich small cysts.
Imaging.
Characteristic sunburst appearance with central calcification on CT, 10-20%. EUS helps delineate. Cyst fluid protein expression can differentiate from IPMNs with high accuracy.
Generally benign. Risk of cancer.
Generally considered benign. Malignancy risk extremely low. Pancreatectomy suggests if malignancy is uncertain or symptomatic, resection appropriate for 4 centimeters or rapidly growing lesions, more likely symptomatic infusion.
What about mucinous cystic neoplasms, MCNs? Also mostly benign.
MCNs are mucin producing, crucially, no communication with pancreatic duct. Key differentiator, wide histologic spectrum, benign to invasive carcinoma. Histologically, mucin-rich cells, characteristic ovarian-like stroma, estrogen-progesterone positive.
Who gets them?
Primarily young women, 5th decade, rarely men, typically body tail. Increasingly incidental finding, 50% present with vague abdominal pain, 20% history of pancreatitis. Common misdiagnosis, pseudocyst.
What do MCNs look like on imaging? Cyst fluid.
CT. Solitary cysts may be fine septations, often rim calcification, eggshell calcification. Eggshell calcification, larger size, mural nodule suggests malignancy. EUS FNA, mucin-rich aspirate, high CEA 192 ng-mel, low amylase. Accurate diagnosis, 80%.
And treatment. Surgery always required.
Pancreatic resection is standard due to significant malignant potential. Even if appearing benign, risk is too high to watch. Resection curative if no invasive disease. Prognosis for invasive MCNs poorer, but significantly better than ductal adenocarcinoma. Slower growth, less nodal involvement, 50-60% 5-year survival. Adjuvant chemo offered for invasive, especially node positive.
Now, intraductal papillary mucinous neoplasms, IPMNs, also mucin, but involve ducts directly.
You're right. IPMNs are mucinous epithelial neoplasms from main branch ducts, typically 6th, 7th decade, increasingly diagnosed, CT MRI. Wide spectrum, low, moderate, high-grade dysplasia, invasive malignancy, nomenclature standardized.
And classified by which ducts involved?
3 main subtypes. Side branch duct IPMN, BD-IPMN, affects small side branches, communicates with but doesn't involve main duct. Can be focal, multifocal.
Okay.
Main duct IPMN, MD-IPMN, involves main duct itself. Abnormal cystic dilation, columnar metaplasia, thick mucinous secretions oozing from papilla. Focal or diffuse. Significant malignant risk, 30-50% harbor invasive cancer.
High risk.
Mixed type IPMN. BD-IPMN extends to involve main duct. Biologic behavior resembles MD-IPMN, 30-50% invasive malignancy risk. Also high risk.
That's a lot. How are IPMNs managed, given malignant potential and types? Hashtag 5.2 management strategies for intraductal papillary mucinous neoplasm.
Management guided by sophisticated risk stratification international consensus guidelines, 2017 update. Classify features into worrisome and high-risk categories, dictating approach, observe, biopsy, resect.
What are these worrisome and high-risk features?
Worrisome features, imaging, BD-IPMN, cyst 3 centimeters enhancing mural nodule 5 millimeter, thickened enhancing wall, main duct 5-9 millimeter, abrupt caliber change, plus distal atrophy, lymphadenopathy, clinical pancreatitis, elevated CA19-9 cyst growth 5 millimeter 2IR.
Okay, and high risk.
High-risk features, enhancing nodule 5 millimeter within cyst, main duct 1 centimeter, clinical jaundice. These are red flags pushing towards intervention.
Has genetic analysis of cyst fluid helped predict malignancy?
While mutations, KRAS P53 evaluated, genetic analysis has not yet consistently improved prediction or surgical selection beyond existing clinical guidelines. Ongoing research, but decisions rely more on imaging patient features currently.
So if a patient has a branch duct IPMN, how is that managed? Always removed.
For BD-IPMNs, cysts with worrisome features on CT MRI should get EUS. If high-risk features present, surgical resection strongly recommended. For asymptomatic patients with no worrisome high-risk features, surveillance often reasonable, considering age comorbidities.
What about size?
Asymptomatic 3 centimeter, worrisome. Strong consideration for resection. 2 to 3 centimeters consider resection or observation based on age condition. 2 centimeters low risk, most appropriate for surveillance.
Why surveillance sometimes preferred, even with malignant potential? Seems counterintuitive.
Overall invasive risk in BD-IPMNs 10-15%, yearly regression 2-3%. For small asymptomatic tumors, watchful surveillance often reasonable because risk relatively low, many patients older. Time for malignancy to develop might exceed life expectancy, making surgical risks outweigh benefits. Careful balance, always individualized.
In contrast, main duct IPMNs, surgery the standard.
For MD-IPMNs, yes, surgical resection is cornerstone due to significantly increased malignant risk, 30-50% invasive cancer at presentation. All surgically fit patients with MD-IPMN should be considered for resection.
Clinical predictors.
Jaundice, elevated liver enzymes, mural nodules, diabetes, main duct diameter, 7 millimeter, current guidelines, 5 millimeter worrisome, 1 centimeter high risk. Clear signals for surgery.
How do you confirm diagnosis planned surgery for MD-IPMNs?
CT dilated main duct, cysts, nodules. MRCP-EUS, important secondary studies, localized nodules, classify, assess fluid solid, viscous, clear, mucin, high CEA, 192. Note, CEA elevation predicts mucinous changes, not necessarily invasion.
And mixed type IPMNs, treated like main duct type.
Yes, surgical resection indicated due to significant invasive risk, 30-50%. Biology more aggressive than pure branch duct.
For all IPMNs needing surgery, what does resection involve? Survival outcomes.
Partial pancreatectomy, primary treatment for high-risk lesions.
Right.
Target specific lesion for BD-IPMN. For MD-IPMNs, more complex due to potential spread. Right-sided pancreatectomy often preferred if no diffuse polyps nodules. Intra-op frozen section of neck margin crucial. Total pancreatectomy reserved if margin positive. High-grade dysplasia invasive carcinoma, 15% conversion rate. Debate over total versus partial decreasing with longer follow-up.
Survival rates versus other pancreatic cancers.
Significantly better than PDACs. Non-invasive IPMNs. Excellent survival. 97% 1-MI or 77% 5-ER. No difference between IPMN, borderline IPMN. Significant difference between non-invasive IPMNs. Invasive. 72% 1-MU-WIR, 58% 3-ER, 43% 5-R. Survival heavily dependent on invasive component. early detection key.
After resection, long-term surveillance needed. Recurrence risk.
Yes, surveillance of remnant pancreas advised due to recurrence risk, 5.22%. Regular imaging follow-up, decision to terminate based on age condition, reoperation considered for recurrence progression.
A lot of nuance for cystic lesions. Now, the silent killer, adenocarcinoma, pancreatic ductal adenocarcinoma, PDAC. Truly devastating. 2018 estimates, 55,000 U.S. cases, 44,000 deaths. Dramatic increase from 1995, likely aging population, better diagnostics. 9th most common cancer diagnosis, but 3rd most common cause of cancer deaths, outranking breast cancer.
Sobering.
Prognosis remains dismal. Overall, 8% 5-year survival. Major reason. Most present with locally advanced or distant metastatic disease, already spread when diagnosed, truly a silent killer, often no symptoms until advanced.
Any hope for earlier detection? Or just too aggressive?
There is hope. Much research focused here. One study suggested average 5 years required for PDAC to acquire metastatic ability. Implies potential window of opportunity when still locoregional, potentially curable. Fuels intense efforts for earlier detection, screening, though not yet reality for general population.
Who's typically affected? Demographics.
Men slightly more, 1.3.1. African American slightly higher risk. Risk increases with age. 6 decade means 72 years. Disease of older age.
Risk factors.
Environmental factors.
Most notable, smoking. Strong dose-response relationship, 1-3x increased risk versus non-smokers. Risk persists years after cessation, though decreases over time. Chronic pancreatitis, occupational exposures likely elevated risk, magnitude uncertain, obesity, maybe up to 3x increased risk. Unclear if obesity itself or comorbidities.
And the complex diabetes relationship, not always clear which causes which.
Very complicated. Studies suggest new onset diabetes, especially elderly, low BMI, weight loss, no family history, has significantly higher PDAC incidence. Diabetes may be caused by the cancer interfering with insulin. Can precede cancer diagnosis by up to 36 months, potential window for early diagnosis efforts in this high-risk group. Long-term diabetes may also increase risk, confounded by obesity, key red flag.
Hereditary factors, runs in families.
Yes, inherited predisposition in range of settings. 20% hereditary cases from known syndromes, 80% from familial pancreatic cancer, FPC, with no identifiable syndrome. Hereditary pancreatitis, PRSS1, TEC2, and K1, 50-fold increased risk.
Huge increase. Other syndromes.
Peutz-Jeghers, STK11, 100 times risk. Cystic fibrosis, CFTR, 30x risk. Chronic inflammation. Familial atypical melanoma, CDKN2A, 20x risk. Hereditary breast ovarian, BRCA2, 10x risk. 10% high-risk PDA families have BRCA2. Lynch syndrome, mismatch repair genes, 8x risk. Familial adenomatous polyposis, APC, 4x risk. Complex genetic web.
And familial pancreatic cancer, FPC, no known gene yet.
FTC. U2 first-degree relatives with PDAs, no other syndrome, 18-fold increased risk versus general population. Risk increases with more affected relatives or earlier diagnosis, 50 years. Suggests unidentified autosomal dominant genes reduce penetrance. Area increasingly appreciated screening management guidelines evolving.
Deep dive into risk factors, but for most sporadic cases, the genetic story. How does it develop molecularly?
While inherited forms exist, most PDAC sporadic. Develops via sequential pathway. Pancreatic intraepithelial neoplasia. Pannin-free cancerous lesions. Invasive cancer. Key tumor suppressor genus and cogenes involved. Importantly, even in sporadic cases, up to 5% harbor germline mutations. Leads to NCCN recommendation. Consider germline testing for all PDAC patients, regardless of family history. Relatively new, important understanding.
So starts with panning. What is panning? Already cancer.
Not quite. Histologically defined progressive abnormalities of ductal epithelium, spectrum grading system. Pannin 1A, columnary mucin-producing basal nuclei. Pannin 1B, papillary architecture. Pannin 2, nuclear typia, abnormal nuclei enlarged, crowded. Pannin 3, carcinoma in situ. Prominent nuclear abnormalities, loss of polarity, marked atypia, abnormal cell clusters in lumen. Stage just before invasive cancer, still confined.
Which genes involved at which stages? One kicks it off.
KRAS2, oncrodine activated in 95% PDACs. Considered initiating event. Point mutation, band stuck on uncontrolled signaling. Earliest abnormality in pannin progression, 36% pannin 1, 44% pannin 2, 87% pannin 3. Very early, common driver.
KRAS early driver. What about tumor suppressors? The brakes.
CDKN2A encodes P16 protein, crucial early player. P16 normally breaks cell division. Mutation loss, break on, uncontrolled cycle. Also identified early, 30% pannin 1, 55% pannin 2, 71% pannin 3. 90% PDACs show P16 loss.
Okay, P53.
P53 tumor suppressor regulates proliferation cell death, rare in early pannins,
Right.
but mutated in 79% invasive PDAs, critical for non-invasive transition.
Occurs late.
Loss of function, EDs, TGFR, decreased inhibition of growth, observed 20-30% pannin 3 localized cancers, but 78% widely metastatic tumors. Highlights role in acquiring metastatic potential. Clear, stepwise genetic progression.
Highly detailed roadmap. Given aggressiveness, typical clinical signs, the clues.
Defining symptom for periampullary tumors, head, near bile duct, is jaundice. Yellowing skinese from bile duct obstruction, often called painless jaundice, but many do have pain to upper abdomen radiating to back. Weight loss, extremely common, 50%. For body tail tumors, pain and weight loss even more common, presenting symptoms, jaundice less likely early, and new onset diabetes, especially elderly plus weight loss, can be early warning sign.
Physical exam findings. Anything doctor can feel see.
Except jaundice, often unremarkable, contributes to silent killer rep. Few classic, less common signs are strong indicators. Courvoisier sign, palpable, distended, often non-tender gallbladder, associated with slow progressive tumor occlusion versus shrunken gallbladder with stones, strongly raises suspicion.
Signs of widespread disease on exam.
Yes. Metastatic disease, enlarged firm lymph node, left supraclavicular, Virchow node, enlarged nodes around belly button, Sister Mary Joseph node, extensive peritoneal spread, tumor felt in parorectal area on DRE, Bleuler shelf, all grave signs of advanced disease.
Powerful, sobering clues. How confirm diagnosis? Diagnostic arsenal.
Combination of lab evaluation and sophisticated imaging.
Huh.
Initial labs, liver function, coagulation, nutritional assessment, albumin. Address malnutrition pre-op, elevated bilirubin expected with jaundice.
Tumor markers. Specific blood tests.
CA19-9 most sensitive 79%, specific 82% for PDAC. Limitations. Falsely elevated with biliary obstruction. 10-15% people Lewis antigen negative don't elevate CA19-9 even with cancer. Despite caveats, most reliable for pretreatment EVIL and post-treatment surveillance. Used as predictive prognostic marker. Staging laparoscopy indication, normalization post-neoadjuvant. Other markers, CEA, AFP, measured but less specific.
Go-to imaging for diagnosis and spread.
Multi-detector CT is imaging of choice. Accurate for biliary obstruction level, tumor relation to critical vessels, regional metastatic disease. Recommend 3-phase scan, thin slices, 3D reconstruction for periampullary disease, high sensitivity, 85%. PDAC, typically hypoattenuating, darker in portal venous phase due to poor blood supply. Preferred initial imaging.
ERCP, diagnostic role or more treatment.
Frequently used for jaundice patients. Biopsy, palliation via biliary stent. Usefulness questionable for surgical candidates. Pre-op drainage might increase wound infection, though overall complication rates unchanged. Largely reserved for therapeutic palliative interventions now. Metal stents preferred for neoadjuvant chemo patients stay open longer.
And EUS, endoscopic ultrasound.
Widely used. Arguably most important for tissue diagnosis via FNA, 92-95% accuracy, superior to brush cytology. Crucial for molecular evaluation guiding neoadjuvant therapy. Useful for peritumoral vessels nodes, identifying small tumors, 2 centimeters missed on CT. Complementary role.
MRI in this context, as good as CT.
MRCP valuable for detailed pancreatobiliary anatomy, especially useful for cystic lesions, slightly superior to CT. Advantages. Non-invasive, no pancreatitis risk, 3D reconstruction, no radiation.
Biologic imaging like PTCT.
FTG PET-CT increasingly used. Detects cancer based on preferential uptake of labeled glucose by active cells. Potential benefits. Differentiating benign malignant, POIG, AIP versus PD, identifying unsuspected metastatic disease, altering planning 10% cases. Caveats. False positives from inflammation. Risk-benefit not fully determined for routine use. Not first-line diagnostic yet.
Found it, diagnosed it, characterized it. Now map it. How stage PD8 to decide treatment.
Staging adheres to AJC TNM system. Tumor, node, metastasis. Classifies based on size, node spread, distant mets. After biopsy confirmation, EUS-FNA, accurate staging primarily via multi-detector CT, abdomen, pelvis, contrast, 3D reconstruction. Chest X-ray usually sufficient for lungs, CT if suspicious. 8th edition AJCC revised TEAS category from descriptive to size-based, best surrogate for biology prognosis.
How are tumors classified based on CT categories?
Resectable, borderline resectable, or unresectable. Resectable. Localized to pancreas. No SMV portal vein involvement. No abutment, distortion, thrombus encasement. Preserved fat plane around SM celiac branches, including hepatic artery. Traditionally direct surgery. Increasing trend? Pre-op chemo, even for respectable potential shrink-improved outcomes, varies by institution.
Borderline resectable. Gray area challenge.
Evolving definition. NCCN criteria. Venous. Solid tumor contact, SMV portal vein 180 degrees or 180 degrees with contour irregularity, thrombus, but suitable vessel for safe resection reconstruction. Arterial. Hepatic artery contact, abutment encasement, without extension to celiac bifurcation, allowing resection reconstruction. Or SMA contact 880 degrees. Start surgical resection only after neoadjuvant therapy, shrink tumor. Type duration, neoadjuvant vary.
Unresectable, surgery off table.
Clear distant metastasis, including nodes outside resection field, ascites, or vascular involvement beyond borderline criteria. Surgery typically not performed. Treatment focuses on systemic therapies palliation.
Staging laparoscopy still common? Or imaging good enough?
Advocated to reduce non-therapeutic laparotomies. Can identify additional unresectable disease, small peritoneal implants, missed on CT in up to 30% resectable cases.
Right.
But some argue modern imaging makes it less beneficial. Consensus. Selective use for high-risk patients, large tumors 3 centimeters, high CA 19/9/100, uncertain CT, body tail tumors, significant weight loss, malnutrition, pain. No level light data for routine role, surgeon's discretion, peritoneal cytology. Unclear role, but positive findings, very poor prognosis, like Mets.
Complex staging. Ultimately, for resectable disease, surgery only a potential cure. Let's talk procedures.
Surgical resection remains only potentially curative treatment. High stakes, success hinges on meticulous technique.
Head tumors. Whipple procedure. Pancreatic duodenectomy. Standard. Walk us through conceptually.
Whipple standard for head tumors. One of the most complex intra-abdominal operations. History 100 hours. Outcomes improved significantly recently. Conceptually. Remove head of pancreas, entire duodenum, gallbladder, part of bile duct. Then, intricate reconstruction. Reconnect remaining pancreas, bile duct, stomach to small intestine.
Significant removal, complex rebuild. Key stage critical moments.
Begins with thorough exploration for hidden mets, deemed inoperable. Cocher maneuver. Mobilize duodenum pancreatic head away from major vessels, vena cava, aorta. Meticulous dissection around vital intestinal vessels, SNV, SMA, preserving or safely reconstructing is paramount. Gallbladder removed, bile duct dissected, duodenum often divided past stomach, pylori sometimes preserved.
Pancreas division, crucial there.
Before dividing, must assess liver intestinal blood supply, variations, blockages, key maneuver. Temporarily occlude artery, ensure collateral flow. If interrupted, need alternatives, bypass. Once vessels clear, tumor resected with involved organs. Reconstruction begins. Remaining pancreas connected to small intestine loop, then bile duct, same loop, finally stomach duodenum connected. Restore digestive tract continuity. Drains often placed, feeding tube maybe. Testament to surgical precision, body's resilience.
Astonishing detail precision. Body tail tumors, less complex surgery.
Body tail tumors rarely resectable at presentation. Lack of symptoms, small tumors, large advance when diagnosed. Only 5-7% undergo surgery. Shorter median survival than head PDACs. Resected tumors typically more advanced. Celiac axis involvement is contraindication. Splenic artery vein involvement does not preclude surgery. Remove with spleen. Resectable, distal pancreatectomy and en bloc splenectomy. Remove spleen with tail.
How done conceptually?
Distal pancreatectomy splenectomy, retrograde, spleen pancreas mobilized lateral medial or antegrade, medial lateral pancreatic neck divided early. Antegrade, part of radical antegrade modular pancreatosplenectomy, aims for more complete lymph node removal. Essentially, detach body tail plus spleen plus surrounding nodes, divide pancreas near neck, pancreatic duct remnant sealed, suture or stapler, similar fistula risk.
Minimally invasive laparoscopic robotic for these complex resections. Becoming standard.
Growing interest, minimally invasive distal pancreatectomy. Laparoscopic, LDP, may offer advantages. Smaller incisions, shorter stay. Increasingly used benign conditions, usefulness for PDAC still validated. Seems comparable safety short-term outcomes, crucial. No randomized trials versus open LDP for cancer yet. Lack definitive high-level evidence.
Whipple laparoscopic robotic. Heard buzz.
Minimally invasive pancreatic duodenectomy rising popularity, but lacks strong evidence, clear benefits. Some studies raise concerns. Single institutions favorable, broader analyses concern increased morbidity mortality. LIBOR-2 trial terminated early, significantly increased mortality, minimally invasive, 10% and T's 2% open. Debate continues. Robotics alternative adjunct addresses some laparoscopic limits, vascular control, reconstruction. Few centers pursue, too early predict widespread adoption. Open pancreatic duodenectomy remains standard of care for head tumors. Complexity means incision size less factor than technical precision.
Very clear message. Even successful surgery, complications common. Most common ones managed.
Despite reduced mortality, morbidity common, 30-50% Whipples. Delayed gastric emptying, prolonged difficulty tolerating food, frequent, 5-15%. Pancreatic leak fistula, major morbidity, 5-22%. Defined by digestive fluid leak, high enzymes, most low-grade, controlled with drains, resolve. Anastomotic leaks, bile duct, small bowel, rare, 5%. Infectious complications, abscess, wound infection, slightly more common, may need drainage care. Pancreatic endocrine exocrine insufficiency can occur. Risk unpredictable, depends on remaining gland health pre-op.
Let's discuss ongoing surgical controversies. Palliative bypass for unresectable disease, open up, can't remove, FABA, still bypass.
Despite advanced imaging, 10% found locally advanced metastatic at operation. If mets seen during staging laparoscopy, generally not indicated, proceed full laparotomy palliative bypass. Endoscopic stenting preferred. If unresectable mets discovered during full laparotomy, decision for biliary GI bypass individualized. Options: operative palliation or close pursue endoscopic interventions. No definitive survival QOL data comparing. Decision hinges on symptoms, health, projected survival. Widespread cancer, endoscopic favored, short life expectancy. Prior obstructive GI symptoms need duodenal stent, GI bypass prudent. Good functional status, low volume mets locally advanced, operative biliary bypass reasonable.
Whipple type, pylorus preserving versus non-pylorus preserving. Keeping stomach outlet matter.
A pylorus preserving proposed reduced dumping bowel reflux. But despite enthusiasm, no randomized controlled trials show superiority. Most surgeons choose based on training experience.
Pancreas connection. Pancreaticogestomy versus pancreatic gastrostomy. One safer for leaks.
Pancreaticogestomy. Pancreas jejunum. Achilles heel due to fistula frequency. Pancreatic gastrostomy. Pancreas stomach. Some studies reported reduced leak, but not reproducible in several randomized trials. Most surgeons prefer pancreatic jejunectomy. If duct not identified, invagination or pancreatogastrostomy may be considered.
Drugs to reduce fistulas. Common difficult complication.
Idea. Inhibit exocrine secretion, quiet pancreas down. Somatostatin analogs evaluated, mixed results. European studies suggested benefit. North American trials didn't confirm. Older drugs. Baseriotide, newer, longer action. One MSKCC trial showed significant reduction grade 3 plus fistula leak abscess, but results not reproduced outside this institute.
Routine use remains controversial.
Extensive lymphadenectomy. Remove more nodes, improve outcomes.
Context. 75-80% node involvement at Whipple, 80-85% recurrence. Radical lymphadenectomy proposed, extended nodes. But randomized trials show no improved survival, increased morbidity, delayed gastric emptying, fistula dumping. Conclusion. Standard pancreaticoduodenectomy is operation of choice. More, not always better. Quick one. Reconstruction. Anticolic versus retrocolic duodenogenostomy. Position matter.
Emerging data suggests anticolic, loop passes front of colon, may improve gastric emptying versus retrocolic, behind. Subtle but potentially important technical detail.
Big debate. Drain versus no drain after resection. High leak risk. Imagine what a drain.
Significant controversy. Drains routinely used due to high fistula risk. Downsides. Increased infection, pain, prolonged stay. RCTs evaluated. 1. No difference complication rate. Larger multi-institution RCT, increased morbidity, 4x mortality. No drain group. Drain decreased adverse clinical impact of fistula. Good results without drains, only high-volume specialized centers. Conclusion. Use of surgical drain considered standard of care.
Settles that for now. Emerging tech like irreversible electroporation.
Future. Irreversible electroporation investigated locally advanced non-resectable or margin accentuation. Uses electrical pulses, kills tumor cells, preserves collagen structures, vessels, ducts. Proposed improved local control survival. Utility remains to be determined. Interesting tech, not widespread solution yet.
Beyond surgery, multimodal treatment crucial. Adjuvant, neoadjuvant therapies, chemoradiation before-after surgery.
Indeed. Optimal outcomes require multimodal treatment. Surgery plus chemo plus non-radiation. Chemo, widely accepted adjuvant after surgery. Radiation usefulness adjuvant, increasingly questioned. Europe stopped routine use. U.S. still uses. Ongoing debate.
Key trials shaping adjuvant therapy, defining standard care post-op.
Early trials, GITSG 1974, showed survival benefit combined chemo plus radiation. Pivotal ESPAC1 later suggested chemoradiotherapy could be detrimental. Chemo alone, 5FU, improved survival. Game changer. Chemo beneficial, combined chemorad not always.
Radiation routine adjuvants, adjuvant out, chemo in. What chemo became standard?
Kiapose 001, 2007, established adjuvant gemcitabine, different drug, no radiation standard, improved disease-free survival. Other trials refined ESPAC3, similar OS 5FU versus gemcitabine, but gemcitabine, less toxicity, better compliance, preferred choice.
Very latest adjuvant therapy, new gold standard.
ESPAC4, most recent international RCT, gemcitabine plus capecitabine versus gemcitabine mono. combination superior, significant improvement median OS, new standard adjuvant. Most recently, Prodigy 24, ASCO 2018. Mfolfirinox, aggressive 4-drug versus gemcitabine. Mfolfirinox, significantly longer DFS OS, promising, but higher toxicity, hard administered post-op, often reserved fitter patients.
A lot of evolution adjuvant. What about neoadjuvant? Chemoradiation before surgery.
Rationale, multifaceted, compelling. 1, ensures all patients get multimodal therapy, 25% don't get adjuvant post-op, guarantees critical component. 2, maximize efficacy, therapy to intact land, establish blood supply, reach tumor better. 3, allows real-time assessment response. If progresses during neoadjuvant, aggressive biology prevents futile extensive surgery.
The stress test for tumor. See if too aggressive for surgery attempt.
Exactly. Physiologic stress test helps select patients who tolerate major surgery, may improve negative margin rates, reduce node mets by shrinking tumor pre-removal. Retrospective data, MD Anderson supports. Higher completion rates, all therapy, better outcomes for completers.
Strong evidence supporting neoadjuvant, especially borderline cases.
Yes, particularly borderline resectable. Pre-op C1 RCT, resectable borderline. Pre-op chemoradiotherapy versus immediate surgery. Neoadjuvant group significantly better OS, DFS, no significant increase adverse events. South Korea trial also showed neoadjuvant for borderline improved OS, R0 resection rate.
Seems particularly useful borderline, giving chance at surgery.
Precisely. Patient significant venous borderline arterial involvement. Neoadjuvant crucial. Helps identify who benefits aggressive multimodality therapy plus vascular reconstruction. But aggressive treatment needs experienced multidisciplinary team, ideally clinical trial setting.
Chemotherapy for metastatic PDAC. Most patients present this way.
80% present, locally advanced metastatic. Primarily managed chemo. Regimens for metastatic influencing resectable borderline treatment. Gemcitabine standard since late 90s. More effective regimens emerged. Fefofirinox, 5FU, oxaliplatin, irinotecan, leucovorin significantly improves median OS PFS versus gemcitabine alone. Used neoadjuvant borderline good performance status. Gemcitabine plus nab-paclitaxel also improves OS PFS versus gemcitabine alone.
Targeted therapies. Successful in PDC.
Less promising so far. Erlotinib plus gemcitabine. Statistically significant but marginal OS PFS improvement. Bevacizumab cetuximab plus gemcitabine. No improvement. Chemo remains workhorse, unlike some other cancers revolutionized by targeted therapies.
Finally, advanced disease, not surgical candidates. Palliative options improve QOL, pain obstruction.
For 80-85% not candidate surgical resection, non-operative management preferred. Expedite systemic therapy, optimize QOL by managing symptoms.
Biliary obstruction, jaundice,
Okay.
managed non-surgically.
Yes. Palliation needed frequently. ERCP plus metal stent placement, excellent palliation, jaundice, 90% success. High volume centers, metal preferred, stay open longer. If ERCP fails, percutaneous biliary drainage, drain through skin, bile duct, internalize into gut. If unresectable at laparotomy or non-surgical fails, surgical biliary enteric bypass, Roux-en-Y hepatogenostomy offers excellent long-term patency.
Gastric outlet obstruction, stomach block.
Affects 20% locally advanced PDA. Tumor compresses duodenum. Metastatic and resectable. Endoscopic luminal stenting option. Excellent short-term relief, immediate intake improvement, but limited long-term patency. Tumor grows through. Unresectable at laparotomy. Preventive gastroenterostomy, bypass stomach, small intestine, no increased periop morbidity. If needs surgical intervention, both issues, double bypass.
Hepatocoagulation plus gastrage.
Pain. Prevalent, often severe. Relieved. Affects most advanced disease patients. Palliation paramount. QOL. Medical initial. Anti-inflammatories, long-acting opioids, oral patch. Uncontrolled pain narcotic side effects, celiac nerve block considered. Inject local anesthetic plus absolute alcohol into celiac plexus, nerve bundle. Performed intra-op, US guided, 80% pain relief. CT guided. Aggressive pain management critical, allow patients live remaining time, dignity, comfort.
Comprehensive overview, pediatric diagnosis management. Finally, quickly touch on pancreatic trauma, unforeseen challenge.
Pancreatic injuries uncommon due to deep retroperitoneal location. Mechanism varies by age. Pediatric, blunt abdominal trauma, direct epigastric compression, bicycle handlebars. Body most affected.
Adults.
Penetrating injuries most common. Stem gunshot.
Usually isolated.
Or other organ damage. Isolated rare. 90% have associated injuries. Liver, stomach, spleen, kidneys, colon, major vessels. Diagnosing straightforward unstable patients. Hemodynamically stable patients challenging. Isolated injuries often subtle absence and symptom signs initially. Undiagnosed injuries, substantial complications, abscess, fistula, fluid collection, 60%. Always consider after significant upper abdominal compression injury, cardiac accident, even a patient feels fine initially.
Imaging for diagnosis, challenges.
CT abdomen modality of choice, abdominal trauma, speed, availability. Findings suggest injury. Peripancreatic hematomas, free fluid lesser sac, thickened gerota fascia. MRCP, excellent visualization, duct integrity, fluid, hemorrhage after non-penetrating trauma. Limitations: cost, availability, time, and acute trauma. Importantly, isolated serum amylase not recommended screening tool, 40% transected duct abnormal amylase. Serial quantification increases sensitivity, but abnormal elevation still needs imaging. Most reliable test, duct integrity, ERCP. Limited by pancreatitis risk, availability, trauma severity.
How classified and treated? Severity dictate approach.
Classified using American Association Surgery Trauma, AST, grading system, minor contusion, massive disruption, duct injury, tissue loss. Definitive treatment based on surgical findings. Stable patients, isolated injuries. Major resections possible if severe. Unstable complex injuries. Damage control surgery indicated. Temporary control, bleeding, contamination with drains, not definitive repair. Definitive treatment considered once patient physiologically stabilized. Remember, 75% deaths after pancreatic trauma within 48-72 hours, mostly hypovolemic shock. Immediate stabilization priority.
What an incredible journey through the exocrine pancreas, from its tiny, precise origins to its daily work as a digestive powerhouse, and then the myriad of ways it can go wrong.
Indeed. We've peeled back the layers: intricate development, anatomical mapping, vital digestive role, complex inflammatory storm of acute pancreatitis, lingering scars of chronic pancreatitis, diverse cystic neoplasms, aggressive adenocarcinoma, even trauma.
Yeah.
Really highlights how understanding anatomical nuances, biochemical pathways, genetic predispositions, evolving diagnostic therapeutic strategies is key to truly mastering this critical field.
It's a testament to the body's incredible resilience and complexity. Even facing such profound challenges, our understanding grows, pushing frontiers of early detection, personalized medicine, more effective treatments.
And that's really the provocative thought I'd like to leave you with. Pancreatic cancer, particularly, remains one of the most challenging to detect early. But with the incredible pace of research into liquid biopsies, simple blood tests, and advanced imaging, well, the dream of catching this silent killer at a curable stage might just become a reality. It's a field where every discovery, no matter how small, offers a glimmer of hope